Assalamu alaikum. My name is Dr. Syed Waqas Imam Bukhari. I'm a consultant hematologist at Shaukat Khanum Memorial Cancer Hospital and Research Center. It's my pleasure to welcome you all to the hematology sessions in this year's symposium. We have an exciting program and 3 back-to-back sessions this year of hematological malignancies. So in the interest of time, I would just quickly say that the first hematology session deals with leukemias and myeloproliferative disorders and myelodysplastic syndromes. The second session will deal with lymphomas and myelomas. And the final session will be on bone marrow transplantation. Dr. Bushra, my colleague, is going to moderate the first session on leukemias, MDS, and MPNs. I would invite her to introduce the speakers and start the first session. Over to you, Dr. Bushra.
Thank you, Dr. Waqas. Assalamu alaikum and good morning. So this is our first hematological malignancy session. So we have 4 talks and 4 great speakers. The first speaker is Professor Charles Kurdek. He's a consultant hematologist and professor of hemato-oncology. He's a director of bone marrow transplant unit. He's an academic director for Center for Clinical Hematology, University Hospital Birmingham and NHS Foundation Trust. He's the current chair of UK NCRI AML Working Party. He's the recent president of British Society of Blood and Bone Marrow Transplantation and chair of the UK Stem Cell Strategic Oversight Committee. He's a past president of British Society of Hematology. He was a medical director of the Anthony Nolan from 2010 till 2014. His main research interests include the development of novel drugs and transplant therapies in myeloid leukemias, and he leads the Bloodwise UK Trial Acceleration Program. He's a cricket lover and follows it avidly. So we will start with his talk now. Over to you.
I'm very honored to be given this opportunity to present at this wonderful symposium, and I'm only sorry I can't be with you in person. What I want to present today is a summary of strategies that are emerging for management of adults with acute myeloid leukemia. And I am particularly focusing on strategies that may be developed to improve outcomes in these patients. But first, perhaps we could focus on which patients with acute myeloid leukemia should proceed to transplant. These are my disclosures. And first of all, I want to focus on how important an allogeneic transplant has become in the management of acute myeloid leukemia in 2021. And there's a number of reasons for this. The first is a recognition of the potency of the anti-leukemic effect delivered by an allograft in AML, particularly, largely because of a manipulable graft versus tumor effect. The second is that the toxicity of allogeneic transplant has steadily declined. We audited it on our large unit in Birmingham on 200 patients recently, and our 100-day TRM for adults having an unrelated transplant is 3%, rising to about 12% at 1 year. That's largely because of improvements in supportive care, better tissue typing, and I think improvements in GVHD prophylaxis and management. We're also all aware that there's increased donor availability because of increased size of unrelated registries, and also the really important demonstration that the use of post-transplant cyclophosphamide permits a haploidentical transplant to be delivered with relative safety, although there's still some controversy about the GVHD risks and the relapse risks with such a procedure, but nonetheless, haplos and to some degree cords provide treatment options where none existed for many patients. And finally, the really interesting biology is that the hazard ratio of relapse is about 0.65 in patients who have an allogeneic transplant compared with standard chemotherapy. And it's a consistent 65 or 70% reduction in relapse risk across all cytogenetic groups, as demonstrated by this really important HOVON analysis. So this graft versus tumor effect is potent, and it's consistently exerted, regardless, it would appear, of disease biology. So when we think about which patients should be taken to transplant, we're conscious that increasingly decisions about transplant are personalized, and that they depend really on the benefit of transplant in terms of reducing relapse, outweighing attendant transplant-related mortality. So we've become more sophisticated, haven't we, about predicting relapse risk. We'll talk a little bit about molecular and cytogenetic stratification, and also MRD being very valuable tools now for predicting with increasing accuracy the risk of relapse in patients treated simply with intensive chemo. And then we're also becoming better at, in terms of determining transplant-related mortality. So there's an ever-expanding literature now on the utilization not only of cytogenetics, but also molecular abnormalities in terms of predicting outcome with chemo. I'm not going to deal with it exhaustively, but these data, and this is integrating cytogenetic abnormalities and specific molecular abnormalities, such as on the good risk side, CBP alpha biallelic mutation compared with a TP53 mutation. At the same time, we know that quantitation of MRD, either using flow technology or leukemia-specific transcripts in NPM1 mutated AML, are very valuable in terms of identifying patients with a high risk of relapse. Look at the right-hand panel. This is work from David Grimwade's lab, showing that if you are MRD positive, have less than a 3-log reduction in circulating NPM1 transcripts after in the peripheral blood after 2 courses of intensive chemo, your risk of relapse is very high, be a good transplant candidate. But if you're MRD negative, your outcome, because of a low relapse risk, is very favorable. And similarly, we know that flow MRD is assisting us in risk stratification. And finally, I think major advance in terms of utilization of the HCTCI score in predicting patients with a very low transplant-related mortality and concomitantly good transplant outcome compared with patients with scores of greater than 3 who have really a very substantial TRM. And this is particularly important as we start thinking about extending allografts to patients over 60, an area of real growth, but it's clear that patients over 60 with a HCTCI score more than 1 actually seem to have much greater toxicity than we predict in a younger person. And in our unit, we're very reluctant to be allografting patients with a high HCTCI score over 60. So let's just deal with who should go to transplant. I said it's a dynamic, personalized assessment, predicting the risk of relapse with chemotherapy alone on the one hand, and predicting the risk of transplant. So let's just take a patient with good risk cytogenetics or NPM1 positivity who's MRD negative in the peripheral blood after 2 courses of induction chemotherapy. Well, their likelihood of relapse if treated with chemotherapy alone is 25 to 30%. Okay, so if we transplanted them, certainly their risk of relapse would come down. And we know from the Cornelison data, it's a reduction of 60 to 70%. So their relapse risk comes down to, I don't know, maybe 15%. So there's a benefit to that patient of about 10% in terms of reduction in relapse risk. And if you work on the assumption that patients who relapse after intensive chemotherapy, their outcome, even if they get to a second transplant, is really quite poor. And there's a number of registry studies demonstrating that from the time of relapse, disease-free survival is only about 15 or 20%. So essentially, if you relapse, we can call that mortality. So there's a 10% benefit to the patient by reducing the risk of relapse. But of course, the transplant's going to have about a 15% mortality. So it's abundantly clear for patients such as that they shouldn't proceed to transplant. Let's turn, however, to a patient who was MRD positive, let's say the MPM1 positive transcripts. Well, that patient, as we've just seen, has a 70 or 80% risk of relapse. That's going to come down to about 30 or 40% after an allograft. We know that. And that's a benefit in terms of reducing the risk of relapse of 40 or 50%. Well, in that case, if the transplant-related mortality is only 15%, you can see that the patient will clearly benefit from an allograft. And you go through these individualized calculations and you can identify that it's when a patient has a predicted risk of relapse of north of 40 or 45%, that the benefit in terms of reduced relapse, the benefit in terms of reduced death from relapse easily outweighs toxicity of a transplant. And so our policy on our unit is fit patients who have a relapse risk more than 45%, we consider good allograft candidates. And of course, as the relapse risk becomes higher, then you're prepared to tolerate a higher TRM, a more mismatched donor, and maybe a haploidentical transplant, or possibly even some additional comorbidities. So I want now, in the main part of the talk, to turn to how we should transplant patients, and thinking about the fact that transplant toxicity is no longer the major threat to patients, it's disease relapse. So how might we reduce the risk of relapse after an allograft? Well, there are three strategies. We know that the pre-transplant MRD status is important, so we could target that, maybe do something about giving more chemotherapy or optimize treatment. Second is there's good evidence that the intensity of the conditioning regimen reduces the relapse risk, but it's mostly outweighed by excess toxicity. So we could think about optimizing the conditioning regimen. And finally, we could think about optimizing this powerful graft versus tumor effect. So let's just go through these. The first fundamental question, I think, is, should patients with AML, should they receive a MAC or a RIC? And there was an important study done by two groups in AML and an important study by Nicholas Kroger in MDS. But I'm going to focus on the studies in AML. This was the German randomized study, took 198 patients, AML, first CR, randomized to receive a MAC regimen or a RIC regimen. You know, critics of this study would point out this is quite an intense RIC regimen, 8-grade TBI. But nonetheless, this is an important study, and it showed no difference in survival or relapse. The other pivotal study, I think, in this area is the US CTN study, the 0901 study, randomized 272 patients to a MAC regimen, either BuCy or Cy-TBI, or to a Flu-Bu2 or Flu-Mel-Ric. And they found in this study that, sure, there was a lower non-relapse mortality with a RIC, 4% plays 16%. There was less GVHD and chronic GVHD, but there was an increased relapse risk, particularly in patients with AML. That translated into a statistically significantly worse DFS in the recipients of a RIC, but in the first analysis, equivalent overall survival, but a subsequent longer-term analysis has shown improved overall survival with a MAC. Well, so that's an important study, but I think there are some caveats here. The first is that in this study, which you can see here, showed a markedly reduced RIC in patients receiving a myeloablative transplant. That relapse rate in this study of about 20% is a lot lower than in many other MAC studies. Rambaldi's fludarabine busulfan study showed a relapse rate, as we'll see, about 40%. Well, that's a bit odd. And also the relapse rate in the RIC arm was concomitantly higher. And again, that's not completely clear. But it's a randomized study. And despite those caveats, we need to be cognizant of the fact that certainly in this study, there was a clear benefit in terms of a MAC regimen. The other important part of this study is a linked JCO paper by Chris Hourigan, which asked, not doing conventional flow MRD, but took a single blood sample pre-transplant and did NGS analysis. And that showed in patients who were MRD negative, so that's these two curves here, this dotted red line and the solid blue line, that actually the outcome was similar between recipients of a MAC and a RIC. But very provocatively and interestingly, what it showed was if you were MRD positive and you had a RIC, your outcome was much worse than if you had a MAC. So I'm now going to just turn a little bit more to think about MRD, and I want to describe to you a study that we just published from the NCRI AML group, which asked the question of, if you are an older patient and you're deemed that it's not possible to have a MAC regimen, does it matter what RIC regimen? So we were aware that this sequential regimen developed by Kolb and Schmidt, where you have a block of chemo, then a gap, and then a conventional RIC allograft, was associated with, this is the regimen here, block of chemo, gap, rest, and then a conventional RIC, was associated with some really impressive phase 1-2 data in terms of outcomes in high-risk AML. So in the Figaro study, we randomized 244 patients with high-risk AML, either receive a standard RIC FB2 or Flu-Mel-Campath versus this experimental arm. And what we identified, importantly, I think, in this study, was in translational work led by Sylvie Freeman. This was the first prospective study looking at flow MRD and pre-transplant and post-transplant outcome. All the other studies had been retrospective. And what we saw was indeed pre-transplant MRD was associated with an increased risk of relapse, actually not as high a risk as had been reported in retrospective studies and in then unsupervised analysis that this maintained held true, and the threshold was 0.2%. So we then looked at what is the impact of pre-transplant MRD positivity, and it doubles your relapse risk. But nonetheless, the patients who were MRD positive in this study still actually had quite a nice long-term 2-year overall survival. So our interpretation is, sure, it's better if a patient is MRD negative pre-transplant, but actually it's still reasonable to take MRD positive patients in morphological CR to a transplant using either one of these regimens. So this was the results of the Figaro study, no benefit of intensification with the Flamzabue regimen. So in our mind, FB2 remains a perfectly sensible RIC regimen, and there's no evidence that dose intensification is going to improve outcomes. So in the current COSI trial that's recruiting through the UK, we're asking some pivotal questions in this area. The first is, does it matter what is the last course of chemo you have before you go to transplant, particularly with impact on MRD? So we measure MRD before they get randomized for their last course. They either get intermediate dose Ara-C or Vyxeos, and then we measure MRD, and then we look at long-term outcomes. And in the second randomization, having showed the Flamzabue regimen wasn't an advance, we're looking at Thiotepa-based regimens in randomization to the myeloablative, FB4 versus TBF in patients under 55, and over 55, FB2 versus a mini TBF. And then finally, in this part of the talk, I want to think about how you could optimize graft versus tumor effect. Well, there is a very powerful graft versus tumor effect. We know that, and this was work from my colleague Sandeep Nagra, who looked at about 80 patients having and she wasn't quite that many, 70 perhaps, having a RIC allograft, and she looked at their cyclosporin levels and their cyclosporin exposure in the first 21 days. And it's quite telling data. If you have high cyclosporin levels, higher than the mean, your relapse risk is higher and your outcome is less good. So that's a practical point, how we manage these patients, but also it confirms there must be a potent and manipulable graft versus tumor effect in patients allografted for AML. And we've also got a hint that that's true from the Figaro prospective data, where my colleague Justin Loke was able to look at the impact of achieving full donor T-cell chimerism on the outcome of pre-transplant MRD positive patients. So let's just focus on the turquoise line here, this is the outcome if you were pre-transplant MRD positive and you had full donor T-cell chimerism. So actually no impact, as opposed to patients with pre-transplant MRD positivity who didn't achieve full donor T-cell chimerism and were mixed chimeras, again supporting the fact that a graft versus tumor effect may be very important in delivering long-term survival. So we like to think of strategies for post-transplant maintenance as buying time for patients. Let's just say disease relapse occurs before donor CD8 T cells have had a chance to generate a potent graft versus leukemia effect. If you had a therapeutic intervention that delays the kinetics of relapse, ideally one that actually accelerates GVL without GVHD, you may have a good therapeutic strategy. And that's supported by the recent study from Burkert in JCO, showing in patients allografted for FLT3 positive AML, improved survival if they had the FLT3 inhibitor sorafenib. This study is being replicated using gilteritinib. The BMT-CTN 1506 study is completed and we'll have results next year, we hope. Our groups long had an interest in the ability of azacitidine to upregulate tumor antigens and plausibly augment a graft versus leukemia effect. This is a heat map showing azacitidine really lights up expression of tumor antigens on the surface of cells. So in the Amadeus trial, we're randomizing patients who've had an allograft to AML and CR1 to either receive oral AZA or a placebo. This study is now more than 50% recruited, and we're hopeful that it's going to give us definitive answers. So just in this last part of the talk, I want to make my conclusions, I think, about how should we transplant patients with allomandatory AML and CR1. Well, I think the first thing is to say that if you're under 55, a MAC regimen will be well tolerated if you're fit. The Rambaldi data is 7% 1-year TRM with a MAC regimen. So especially in patients who are MRD positive, you should receive a MAC regimen. In older patients, the transplant-related mortality of UCI or flu-bu is too high, really. And so these patients should proceed to a RIC allograft if they're fit. They have to be fit. And these older patients who are MRD positive can still achieve good post-transplant outcomes, but we do need to think of novel conditioning regimens after a RIC regimen. There's certainly no evidence that transplant should be deferred in patients who are in morphological remission but have detectable flow-based MRD. And we need randomized trials to help us understand whether in MRD negative patients they could safely be treated with a RIC rather than a MAC. And finally, we all need to be delivering more transplant studies to inform prospective decision-making. So this is just a small snapshot of what we're doing in the UK, an initiative called Impact, centres across the UK with funded research nurses and a central hub. And the remarkable thing is you empower, you fund the key deliverers, these major transplant centres, you get very rapid recruitment. We're almost now up at 900 patients on randomized studies, and 2 of the pivotal studies being delivered through Impact are the COSI trial we've discussed and the Amadeus trial, and I hope to be able to report those results to you at your upcoming meeting. So thank you for your attention, and I'm very happy to join the question and answer later.
Now we have our second speaker, Dr. Iram Khan. She's a consultant hematologist and associate professor of medicine. She's a section head of hematology oncology in the University of Illinois at Chicago. Her research is focused on translation studies in myeloid malignancies. Dr. Khan's clinical niche at UIC is the care of patients with acute and chronic myeloid malignancies, including leukemia, myeloproliferative, and myelodysplastic disorders. She's a principal investigator on a number of clinical trials in myeloid malignancies. So over to you, Dr. Iram Khan.
Assalamu alaikum. My name is Iram Khan, and I would like to thank the organizers of the Shaukat Khanum Memorial Cancer Center for inviting me to present today at this conference. I'm one of the myeloid malignancy faculty, so today I'm going to talk to you a little bit about treatment updates in the myelodysplastic syndromes as well as the myeloproliferative neoplasms. So we'll start with MDS, or the myelodysplastic syndromes. And I think the first thing that it's important to note is that MDS is a very heterogeneous group of disorders. In fact, if we take all the patients diagnosed with MDS in the United States this year and represent them as these 100 figures, it's very clear that the outcomes are going to be very different. And so we're just going to go through these. And so as you can see, the largest group, which is the last group, is 29 patients who are going to die of completely unrelated causes, which are geriatric causes. About 12 will die of hemorrhagic complications, 20 of infectious issues, and 7 of anemia. So these are sort of linked to the cytopenias inherent in MDS. 2 patients will have iron overload problems. 6 will be recognized as high risk and triaged to transplant, of which 2 will be cured. A third may succumb to transplant complications, and 3 will relapse. And then there's the 24 patients which are going to progress at some point to AML. At the time of progression, it will be possible to aggressively treat some of them, salvage them, and move them to transplant. And only 2 of those will survive. So right off the bat, you can see outcomes are very different in different MDS patients. And importantly, I think the point of transplant outcomes in the MDS phase have much higher odds of success compared to doing a transplant once a patient is transformed to leukemia. So how do we understand which patients are likely to transform and preemptively treat them before they do that? So a number of prognostic scoring systems have been devised in MDS, starting with the IPSS devised by Dr. Greenberg many years ago. And this has subsequently been modified. The revised IPSS incorporates weightage to the degree of cytopenias, weightage to the number of blasts, and has a pretty detailed cytogenetic classification system. And then in 2011, an important paper in the New England Journal reported that when patients underwent targeted sequencing for a number of mutations linked to other cancers, 5 mutations emerged as having independent prognostic value when added to the IPSS, whereby if you had one of these 5 mutations, namely P53, EZH2, ETV6, RUNX1, and ASXL1, the prognostic score drifted down 1 point. So a low-risk patient became parallel to an intermediate 1 patient, intermediate 1 dropped down to the outcome of an intermediate 2, and so on. So this sort of puts some weight behind the importance of molecular testing. MDS patients really should be dichotomized up front into low risk or high risk patients because the treatment approach varies significantly based on which group they fall into. For low risk patients, the goals really are to improve cytopenias, lower transfusion burden, and iron overload, and maintain quality of life or improve it. For high risk patients, the goal is to delay progression to leukemia and improve survival and potentially cure them. So we'll speak a little bit initially about low-risk MDS. So as we talked about, the goals here are improving cytopenias while maintaining quality of life. So the linchpin of treatment is really supportive care here. Erythropoiesis-stimulating agents have been approved and around for a long time for the treatment of anemia in these patients. We have some predictors of response to ESA treatment. It's usually the patients who tend to have a low transfusion requirement and an erythropoietin level of less than 500, which are the likeliest to respond. So this was a scoring system devised by Dr. Hellstrom's group many years ago and is still applicable today. There hadn't been, interestingly, a randomized control trial until very recently, published in 2019, actually, by Dr. Fenot's group, where ESAs were compared to placebo in low-risk MDS and in a clear-cut fashion shown to prolong survival. But we've all been using them for a long time, and that's based on a lot of single-arm studies. In addition, there is a small role and small studies also supporting the addition of GCSF to erythropoietin in patients who are having a suboptimal response to erythropoietin. There's also lenolidomide, which is approved in a very specific niche of 5q minus MDS. We know patients that lack the long arm of chromosome 5 are haploinsufficient in a number of genes. One of these is the genes encoding casein kinase, which has been purported to be one mechanism of the sensitivity of these patients to lenalidomide, because lenalidomide then accelerates the degradation of already low levels of casein kinase, and that complete depletion seems to tip these cells over into apoptosis. Importantly, they do require wild type p53 to undergo cell death. So p53 mutated patients tend to either not respond or quickly show resistance to lenalidomide in the 5q situation. So 5q MDS patients showed pretty impressive responses in a phase 3 trial published in the New England Journal, with response rates of around 50% of patients being transfusion independent compared to only 5% of placebo. They looked at 2 groups of lenalidomide, 2 doses of lenalidomide, 1 placebo group, and pretty clear-cut improvement in transfusion dependence, which was sustained actually for several years. And in comparison, patients that are non-5q minus, published in a later paper, had much more modest responses in the range of around 25%. Which were not as sustained. Buttercept is a first-in-class molecule that specifically improves anemia responses in low-risk MDS and also actually in thalassemia. The way this drug works is that it binds to the TGF-beta family of ligands, and by mimicking the cognate receptor, which is an activin family receptor, and by mimicking this receptor, it absorbs the ligand, preventing it from binding and stimulating SMAD signaling. And in doing so, it allows resumption of normal late-stage erythropoiesis. And in phase 2 studies, such as the PACE MDS trial, was shown to induce significant hematologic improvement in 63% of patients. Predictors of response were low EPO concentrations and the presence of an SF3B1 mutation, which is the one that's linked to ring sideroblasts. And so the phase 3 medalist trial actually only selected patients with ring sideroblasts and showed 38% of patients were transfusion independent, and this was sustained. And this drug was FDA approved based on the results of this study. Immunosuppressive treatment has a very specific niche in MDS, and in the graph on the left, 1,200 cases of hypercellular MDS, aplastic anemia, and hypocellular MDS were compared, looking at survival as well as risk of progression to leukemia in the lower graph. And you can see that hypocellular MDS in the red curve has a prognosis intermediate between that of aplastic anemia in green and hypercellular MDS in blue. Importantly, immunosuppressive treatment has been used historically for these patients, but there's a range of small studies. And so Stahl and colleagues undertook an important study in putting all this data together and looking at 15 different institutions for patients treated with immunosuppressive treatment. And they found the response rate is around 48.8%. And this includes hematologic improvement, which is the bulk of patients. And importantly, patients that have any of these responses seem to have an improved overall survival. And in terms of predicting which patients respond, especially in terms of transfusion independence, it's really the patients who have hypocellular MDS and are treated with ATG and cyclosporin. Thrombopoietin receptor agonists have a role for that very small subset of 10% of MDS patients that have low platelets and clinical bleeding complications. Thrombopoietin receptor agonists that are approved include romiplastim and L-trombopag. Romiplastim is subcutaneous, L-trombopag is oral. Romiplastim binds at the exact same site as the ligand. L-trombopag binds in the juxtamembrane domain of the receptor. These drugs are approved in the treatment of, were initially approved for the treatment of ITP, but they seem to work in aplastic anemia because the thrombopoietin receptor is also expressed in hematopoietic stem cells. However, a higher dose is needed than in ITP. In looking at phase 2 data using thrombopoietin receptor agonists, you can see that the platelet response is in the range of 40%, and bleeding events decrease pretty significantly from 42 to 14%. and there seems to be a sustained platelet response. It is important to remember that some of the original phase 2 study of romiplastim did have to be halted due to a transient increase in blasts that were seen in some patients, but long-term studies did not bear out an increased risk of leukemic transformation. Having said that, I do like to do a bone marrow biopsy on my patients with MDS before I start them on this, just so I have an accurate blast count. Lastly, we'll talk a little bit about iron overload, since it is a concern in patients who are have low-risk MDS, both due to ineffective erythropoiesis as well as transfusional overload. We've known for a long time that iron overload is linked to inferior outcomes in MDS, as well as sort of in the transplant setting when transplanting MDS patients. But there hasn't really been a study showing that lowering iron improves these outcomes. And so the Telesto trial attempted to do this. It was a phase 3 study, later had to be changed to a phase 2 due to trouble with accrual of the target number of patients. And they basically randomized patients to deferrazerox versus placebo, and had a composite endpoint of cardiac, liver, or leukemogenic transformation. So kind of any sort of one of those 3 complications counted as an event, and they were able to show a significant reduction in 3-year event-free survival of 61% versus 47%, and this was statistically significant. And you can see a nice sustained decrease in the ferritin levels in these patients. High-risk MDS patients really require an upfront decision on whether or not they're transplantable, because, as I stated earlier, these are patients who are going to be at risk of transforming to leukemia, and their outcomes are much better when they're transplanted in MDS. For those who are transplant ineligible, options include hypomethylating agents and clinical trials or any approved targeted agents. For the transplant eligible patients, there may also be a role for hypomethylating agent or intensive chemotherapy for cytoreduction if needed. So in the secondary MDS space, there are some therapeutic developments. There is now an oral formulation of decitabine, which is combined with sitazuridine. Sitazuridine is a cytidine deaminase inhibitor, the goal of which is to prevent the degradation of the decitabine when taken by the oral route. And a phase 2 study and now an ongoing phase 3 trial are looking at oral versus IV formulation. And so this is sort of a crossover design of the phase 2 study that's already been published, where in the first cycle, half the patients start with the pill and then cross over to the IV formulation, and the other half start with the IV formulation, cross over to the pill. And after cycle 2, everybody gets the oral formulation. And they were able to show systemic exposure was similar across multiple time points, and importantly, the methylation profile was identical, almost, with less than 1% difference, and clinical responses as well as safety signals were exactly what one would expect with the IV formulation. And this is a survival curve showing sequence A versus B in red and blue respectively, and you can see they're very similar. So this provides us an oral option for the treatment of patients with intermediate to high-risk MDS. In terms of targeted agents, there's a few interesting molecules that I'd like to talk about, specifically in the P53 mutated space, which has traditionally been a very chemo-resistant, difficult to treat population of patients both in MDS and AML. So APR-246 represents a first-in-class molecule, and with a unique mechanism of action, it actually binds to the mutated or the mutant form of the P53 protein and structurally induces changes to this, sort of reverting it to its wild-type conformation and restoring its function of cell cycle arrest and apoptosis. There were 2 phase 2 studies conducted in the United States by Dr. Solomon and in Europe by Dr. Clouseau, and these, in both cases, it was combined with hypomethylating agent. And the study from Dr. Solomon's group was very impressive response rates of 87%, and bearing in mind these are all P53 mutated patients, so that's really impressive. And a number of these patients, 19 specifically of the 45, were able to go on to transplant. So this became a very interesting drug for us. And you could see in the correlative studies that in the patients who did have CRs, there was significant reduction in the p53 variant allelic frequency, as well as protein expression by immunohistochemistry. So it's clearly acting through its target, at least. The European study had slightly more modest response rates of 62%. In MDS, they also had a higher percentage of patients with AML. And what was an important thing to learn from the European study is patients that had more than 30% blast with AML did quite poorly. And so this probably is not a good option for patients with very high blast load. Venetoclax and azacitidine have come to a lot of fame through their activity in AML and have also been looked at in MDS. On the left is a figure looking at relapse refractory MDS, comparing venetoclax to venetoclax plus azacitidine, and you can see that venetoclax alone has very poor response rates of 8%, so it's probably not a good option. But the combination has response rate around 40%, which is not bad in a patient population that is relapse refractory. And you can see that survival curve is significantly better with the combination compared to single agent venetoclax. On the right here, you can see the phase 1b study combining venetoclax and azacitidine in treatment naive, intermediate to or high risk MDS, which is response rates of over 70%. This is an older population. Importantly, the venetoclax here is given for 14 days on a 28-day cycle. So that's important to keep in mind. And based on the results of this phase 1b study presented at ASH, this combination has breakthrough designation. CD47 is a major macrophage immune checkpoint inhibitor, and it basically gives a do not eat me signal in myeloid malignancies. So therefore, using an antibody like magrolimab to block CD47 signaling would then allow other prophagocytic signals to be unmasked and allow these cells to be phagocytosed and destroyed. A phase 1b study presented at ASH this past year looked at magrolimab in combination with azacitidine both in MDS and AML in the frontline setting and showed pretty significant erythroid responses in addition to deep responses, which included cytogenetic responses and MRD negativity in a subset of patients. On subset analysis, p53 mutated patients did seem to benefit, and 16% of patients were able to proceed to transplant. So this is a drug that has garnered quite a bit of interest. One thing to keep in mind about this drug is it does have an effect on-target effect on red cell production and does cause a little bit of anemia in the range of a 1 gram drop in hemoglobin when it is initiated. We'll now segue to the myeloproliferative neoplasms. And while this is an older WHO classification, it nicely shows how really the myeloid diseases are a continuum, where MDS is characterized more by cytopenias and mutations in epigenetic and spliceosomal machinery, whereas myeloproliferative neoplasms are characterized more by cytoses and mutations in proliferative oncogenes like JAK2, KIT, CSF3B, CSF3R, and ZBP1. I'm going to focus on the BCR-ABL negative myeloproliferative neoplasm, specifically polycythemia vera, essential thrombocythemia, and myelofibrosis. While the JAK2 mutation is pretty much disease-defining for polycythemia vera, in the case of ET and myelofibrosis, there can be other driver oncogenes like the calreticulin mutation in about a third of patients, the MIPL mutation in about 10% of patients, and in another 10 to 15% of patients, we really don't know what the driver mutation is. We know that there's a number of things in addition to the mutation that drive disease phenotype, and that includes cooperating mutations, the sequence of acquisition of mutations, as well as the interaction with the microenvironment. This is a nice review paper published by the Mayo and Italian group looking at a treatment approach to polycythemia vera. So essentially, we know from the CYTO-PV study that all patients should be targeted to a very strict hematocrit goal of less than 45 to reduce the risk of major vascular events. And we also know from the ECLAP study that low-dose aspirin is effective in reducing thrombotic complications in all PV patients. Now, beyond that, we should consider whether patients are high or low risk for thrombosis based on the following 2 risk factors that were identified by the polycythemia vera study group early on, and that includes age greater than 60 and a history of prior thrombosis. If patients meet either one of these criteria, a cytoreductive therapy should be considered, and this can be hydrea in the upfront setting. Pegulated interferon also has an emerging role, generally targeted toward younger patients, where it may have a risk in where it may have the benefit of actually altering the disease course by inducing molecular responses. We also have the option of using ruxolitinib, which is FDA approved for patients who are intolerant or refractory to hydroxyurea. Busulfan remains an old remedy that can be used quite effectively in older patients because there is a leukemogenic risk. For the low risk patients, really if they're symptomatic, you can consider treatments like pegulated interferon, but they don't necessarily really need much of anything. Thrombotic risk in ET can additionally be assessed using the IPSET thrombosis score, which also incorporates cardiovascular risk factors as well as the presence of the JAK2 mutation as predictors of thrombosis, and has been well validated in hundreds of patients. Pegulated interferon has been studied in polycythemia vera and ET. On the left is a graph from a phase 2 open label study looking in patients over age 60 with both PV and ET, showing up to 60% molecular response rates in these diseases with interferon alpha 2A, and about 30% of patients had actually molecular remissions, and this is something that no other treatment can do in this space. Now, whether this correlates to reduced risk of leukemic transformation, fibrotic transformation, or thrombotic risk has yet to be seen, but there is a lot of interest because of these molecular remissions that are being seen. However, 22% discontinuation rate, also because there are side effects with pegylated interferon. On the right is data using ropeg interferon, which is interferon alpha 2B, published by the Italian group, and it was compared head-to-head with hydrea in polycythemia vera patients. And you can see for the first year, they were quite similar in their outcomes, but in the extension phase of the study, the pegylated interferon did seem to deepen remissions, and their endpoints were hematologic remission as well as normal spleen size or undetectable spleen. Ruxolitinib was approved based on phase 3 data from the response trial that was done in patients who were refractory or intolerant to hydroxyurea, and the comparator arm was best available therapy, and the endpoint was a composite of greater than 35% reduction in spleen volume as well as hematocrit control not requiring phlebotomy. And you can see that this was achieved in about 20% of patients and had a sustained effect, and that led to the approval of the drug in this space. Now moving on to myelofibrosis, which is a disease with much graver consequences. It's important to have an accurate prognostic scoring system, and so to predict which patients will go on to develop leukemia. And so recent attempts to integrate molecular markers have resulted in the MIPS 70. It's called 70 because it's for patients who are 70 or younger, and that was done with the view of identifying patients who could be transplanted. And they show that basically incorporating calreticulin absence as a negative prognostic marker, as well as greater than or equal to 2 high molecular risk mutations, and these included ASXL1, EZH2, IDH, and SRSF2, seem to add negative prognostic value. And this is the training and the validation cohorts on which this prognostic system was evaluated. So when we're managing myelofibrosis, every patient is different and has unique clinical symptoms. And so for the patients who have cytopenias, treatment should be targeted to those, and especially in the low-risk patients. And erythropoiesis stimulating agents have been looked at and effective if the EPO is less than 500. I do like to make sure that they don't have significant splenomegaly, because you do run the risk of potentially inducing that with ESAs. Other options for anemia would be danazol or prednisone, both of which would also improve platelets and have also been combined in smaller studies with ruxolitinib, as have ESAs. IMiDs are a good option for patients with myelofibrosis, and they do have anemia responses, specifically thalidomide and lenolidomide. Lenolidomide does a lot better with prednisone. Lastly, there's the agents that are in clinical testing, like momelotinib, which is a JAK inhibitor, but also has the off-target effect of reducing hepcidin levels, thereby releasing more sequestered iron and improving erythropoiesis. That is a JAK-independent effect of this drug. Buttercept we talked about earlier as inhibiting TGF family ligands, and CPI is a BET inhibitor that has shown erythroid responses. We'll talk about that a little further on. For intermediate and high risk myelofibrosis, we had one approved agent up until a while ago. Now we have a second, and these are both JAK inhibitors. The first one, ruxolitinib, the second, fedratinib. Ruxolitinib was a first-in-class JAK1 and 2 inhibitor, which was approved based on a composite endpoint of reduction in spleen size, which you can see here in the waterfall plot, as well as a reduction in symptom score, which the symptoms are listed on the table, the third figure on the left. And most of these improvements happen within 3 months and are sustained over time. 5-year follow-up from the COMFORT studies. There were 2 phase 3 studies looking at JAK inhibitor versus either placebo or best available therapy, COMFORT 1 and COMFORT 2, and the long-term outcomes were published recently. And you can see the survival benefit really of ruxolitinib is modest, but this is not the primary endpoint of the study and is a little bit difficult to interpret. So what we've learned from the 5-year data of ruxolitinib is that the median duration of response on the splenomegaly is about 3 years. The survival advantage is modest, and that's confounded by the crossover nature of the trial and secondary analysis. We do know that there are significant rates of anemia and thrombocytopenia, but no new safety signals have emerged. And importantly, almost 70% of patients are off treatment at 5 years, and in a large part this is because of progression of disease, which provides an unmet need. There are a number of areas of interest for therapeutic targeting in myelofibrosis that are nicely summarized in this review by Dr. Schreiber et al. At the top of the figure are pathways related to the microenvironment and fibrosis, specifically TGF-beta inhibition with drugs like galunisertib, fibroblast differentiation inhibition with drugs like venetoclax, which is a recombinant form of a human protein that induces fibroblast differentiation. TGF-beta ligand traps like Buttercept, sympathomimetics because of autonomic innervation of the stem cell niche being important for fibrosis. And aurora kinase inhibitors like alisertib have been shown to inhibit fibrosis by affecting megakaryocyte differentiation. Immunotherapy is an area of interest because of the known curative potential of allogeneic transplant. Interferons have been looked at in myelofibrosis, and while they're a little bit difficult to tolerate, they may have some activity and there are ongoing trials. PD-1 inhibitors are being explored. Importantly, calreticulin mutations result in the production of an abnormal protein that is actually secreted into the circulation and also binds to the thrombopointing receptor and can be targeted potentially with a peptide vaccine strategy or antibody therapies. Proliferative signaling, we know a lot about. JAK inhibitors are 2 of them are approved, several others are in testing. Other pathways that are activated include FLT3, PI3 kinase, hedgehog inhibitors have also been looked at. And then lastly, epigenetic regulators have been looked at mainly in the accelerated and blast phase of myelofibrosis, frequently in combination with JAK inhibitors. The main problem there is myelosuppression. As the final point, hematopoietic stem cell maintenance seems to be affected by IMiDs, and so we talked a little bit about thalidomide and lenolidomide in this space. Telomerase inhibitors like imetelstat seem to be important because HTERT is an enzyme that is critical to maintaining the telomeres in these malignant stem cells, and they seem to be very vulnerable to its inhibition by imetelstat. And lastly, MDM2 inhibitors are an area of active exploration. These are MDM2 negatively regulates p53 and thereby affects apoptosis. And so the MDM2 inhibitors actually stabilize wild-type p53, allowing it to perform its function. The caveat to these inhibitors are that they require wild-type p53 to be effective. BET inhibitors have garnered a lot of interest in MPNs, and this was based on early data from 2018 from Dr. Levine's lab. BET inhibitors basically are a class of drugs that bind to the bromodomain proteins and inhibit their interactions with specific histone residues, thereby affecting gene expression. And one of the networks that seem to be strongly affected by inhibiting bromodomain proteins is NF-kappa B signaling, which in turn leads to the increased cytokine production that characterizes MPNs. And so early data with the BET inhibitor JQ1 was published in preclinical models, and now a newly synthesized, more potent BET inhibitor, CPI 0610, is being studied in myelofibrosis in the manifest phase 2 trial, which actually has 3 arms, one of which is looking at intolerant and resistant patients, the other in suboptimal responders as an add-on, and finally a third arm in treatment-naive patients. And you can see that in addition to reduction in spleen volume and reduction in total symptom score, which is what we saw with the JAK inhibitors, you're also seeing this improved hemoglobin, which seems to be an effect of these BET inhibitors. So that's quite interesting and a beneficial effect of this combination. Lastly, I'm going to talk about the highly challenging clinical scenario of accelerated and blast phase myelofibrosis. So we know from previously published data that p53 mutation in the upper graph here, the 4th bar, is one of the commonest mutations seen in transformed AML. And in paired samples of patients with chronic MPN versus secondary AML, the p53 allele burden really seems to go up. And this led to a combination study combining JAK inhibitor ruxolitinib with hypomethylating agent in accelerated phase, shown in green, and blast phase myelofibrosis. And you can see that responses were the order of months. But there was a pretty impressive reduction in blast count in all patients. But, response rate was around 44%, and really the patients that benefited were the very few that made it to transplant. So there's still quite a bit of work to be done in this area, and I think it's really exciting to see the plenary results of this past ASH, where from Dr. Crispino's lab, it was shown that there is an important tumor suppressor called LKB1 or STK11, which is serine threonine kinase 11. It's the same gene, just different nomenclature. And when this is suppressed, it seems to promote leukemic progression, and the HIF pathway activation seems to be critical to this, the effects of suppressing this tumor suppressor. And so using more potent and selective HIF inhibitors may be of particular therapeutic value in these patients. And so there is definitely a lot of development in this area that we await clinical results from. With that, I'm going to end, and I look forward to all of your questions, and I hope you've learned a few things along the way. Thank you.
Thank you, Dr. Iram Khan. That was a very elaborate update on myelodysplastic syndromes and myeloproliferative neoplasms. Now is our third speaker, who will be giving us a talk on allogeneic transplant in the myelodysplastic and MPN syndromes. He's Professor Tahir Shamsi. He's a consultant hematologist and transplant physician. He's a dean of postgraduate studies. He's professor and chairman of Department of Internal Medicine and director of Bone Marrow Transplant Program in National Institute of Blood Diseases and Bone Marrow Transplant, Karachi, and Children's Hospital, Lahore. He's also the country advisor for Royal College of Pathologists in the UK. His research interests include stem cell biology, hemostasis and novel therapeutics in hematology and oncology. He has a number of publications and has authored 7 books which are published and circulated internationally. So I would like to invite Dr. Tahir Shamsi to begin his talk. Over to you.
Good day, everybody. I would like to thank the scientific committee of Shaukat Khanum Memorial Hospital Symposium. And I'm honored to be invited to talk about stem cell transplantation for myelodysplastic syndrome and myeloproliferative neoplasm. In the next 15 to 20 minutes, I'm going to discuss 2 major indications of bone marrow transplant, allogenic bone marrow transplantation. One is myelodysplastic syndrome, and another one is chronic myeloid leukemia. Before I start, I must disclose my conflict of interest regarding this presentation. I have none. The learning objective out of this presentation is that we are going to discuss these 2 indications of allogenic transplant worldwide. What will be the best time to consider transplant, and what is the impact of disease status and risk group on the outcome of transplant. What are different conditioning regimen, considering the fact that both chronic myeloid leukemia and myelodysplastic syndrome is a disease of middle-aged and elderly people, and what will be the available donors at this age group, match-related, family donors, unrelated donor, transplant, or haploidentical transplant in these indications. And what is the outcome of transplant in the international registries? We're going to discuss all that in my presentation. We can see here there are 3 cartoons which you can see on the left-hand side, top left-hand side is the CIBMTR data. Indications for hematopoietic stem cell transplant in the US, the data collected by CIBMTR in 2013. More or less, these indications remain the same. What I would like you to focus that these blue bars indicate the allogenic transplant, while the green bars tell you the autologous transplant indications. So as we all can see that acute myeloid leukemia in the US is by far the most common indication for allogenic transplant, and this is followed by MDS and myeloproliferative disorders as the second most common indication. All the others, like benign disorders which we come across in this part of the world is completely different. As you can see here, the indication for allogenic transplant in Pakistan, these benign disorders, these 2, beta thalassemia and aplastic anemia, they form almost 60 to 70% of all indications for transplant. And acute leukemia, CML, MDS, they fall very low as far as numbers are concerned. One of the reason may be that the age group of patients who come to us, who live in Pakistan, only less than 4.5% is above the age of 65 years. And the second group, which falls between 55 to 64 years of age, is another 5%. That means only 9%, 9.5% patients above the age of 55, they live in Pakistan. So considering the acute myeloid leukemia, MDS and MPD, which are the disease of middle-aged and elderly, we don't have the surviving population in our cohort. That is perhaps one reason why we don't get to see, when we don't get these patients for transplantation in this part of the world. So what is the role of hematopoietic stem cell transplantation for myelodysplastic syndrome? It is only potentially curative therapy for myelodysplastic syndrome. The other treatment, the non-transplant treatment, started to show some survival benefits, but overall, the majority of patients, they don't survive long enough. We started to see 1 year or 2 years or maybe 3 years survival in those who are intermediate to high-risk patients. And so this hematopoietic stem cell transplant is associated with high treatment-related mortality of 10 to 40%, especially in patients receiving myeloproliferative conditioning, or those with older age, comorbidities, and poor performance status. An increasing number of hematopoietic stem cell transplantations are being performed due to the introduction of reduced intensity conditioning regimen and expanding donor resources, especially the advent of haploidentical transplant and better transplant-related morbidities and better outcome because of this. So what are the goals of hematopoietic stem cell transplantation in myelodysplastic syndrome? Number one is we all can see that it is to maximize quality of life benefit. And the other objective is delay of disease progression and, of course, gain in overall survival. These are the three important goals to achieve while performing bone marrow transplantation. And another one is our goal should be that to minimize stem cell transplantation related mortality in this group. Now, I would like you to focus on the MDS and transplant. Over the years, during last 20 years or so, what we are seeing that still the highest number of transplant carried out for MDS falls above the age of 55 years, under the age of 55 years, which makes about, I would say about 2/3 to 75% of all cases. And this has been the trend all along while MDS being performed. The transplant-related mortality, which used to be around 40%, has certainly significantly reduced to between 10 to 20% in current years. So how can we select transplant patients from the myelodysplastic syndrome cohort? So American Society of Hematology and Cellular Therapy recommend allo transplant in the following setting. Patients with high-risk MDS, IPSS 2, high, IPSS intermediate, high, very high, low-risk MDS of younger patients with or without the presence of poor prognostic features such as the following: bone marrow fibrosis, increased number of bone marrow blasts, and excessive RBC transfusion. And also poor cytogenetics, even if they fall in the category of low or intermediate one. But if they are diagnosed with a poor cytogenetics, they should be considered for as an indication for bone marrow transplantation. And of course, another group of patients who fail to respond to non-transplant treatment, they should also be considered for transplantation. Now, what should be the timing? Immediately after diagnosis, or we can wait till the patient's disease start to progress. So delaying hematopoietic stem cell transplantation for low-risk disease and performing without delay in high-risk disease maximizes the life expectancy. So there's no urgency of performing transplant if the patient is diagnosed in low-risk or very low-risk group of patient. But as soon as the high-risk patients, high-risk disease is identified, bone marrow transplant should be carried out without any delay. However, consider early hematopoietic transplant in low-risk MDS if there is poor cytogenetics present, if there is a percentage of blast is more than 5%, then you can select these patients for transplant. Younger patients with poor cytogenetics certainly should be transplanted as soon as possible. Now, I would like you to focus of the data, especially EBMTR and CIBMTR data of related and unrelated donor transplant. The reason why I'm saying this, because these two data are multi-center data, and the number of transplants carried out are significantly much more than the individual center transplant data. You can see here that in EBMT data, myeloproliferative conditioning was given in about just under 40%, and reduced intensity conditioning was given in just over 60% of the population. Related donor was used in majority of patients as compared to the unrelated donor. Median age was more than 58, and the age range was 50 to 73% patient. 1 year non-relapse mortality was about quarter of patients died because of the non-relapse mortality. And in the younger MUD patients, 16% patient died because of the non-relapse mortality. Disease-free survival and relative risk of relapse was 38%, and 3 years in younger patients, 3 years relative risk of survival, RR, was about 32%. Overall survival at 5 years, 33%. If the patient has a related donor transplant, 5 year for the MUD transplant is only 24% patients were alive. If you look at the CPI-IBMT data, mainly the transplant was done at full match, HLA-related, full match, unrelated donor transplant were about more than 50% patients. Age was 53 years, more or less the same as that of EBMT, and 50-month follow-up for related, and 46 and 39% respectively for unrelated full match and partially mismatched transplant. Here, the data remains almost the same, disease-free survival and overall survival between the EBMT and CIBMTR almost remain the same. So to summarize this particular data, that related donor transplant survival is better, and overall survival is better. Progression-free survival, disease-free survival is better in both European as well as the CIBMTR US data. And if we look into the Chinese BMT multicenter data and compare it with EBMT data, then what we can see here, that for haploidentical transplant, that the disease-free and overall survival in Chinese patients, overall survival at 4 years was 73% in related donor, as compared to just under 60% when the HLA haploidentical matched related donor transplant. So that means a related donor transplant do well when it comes to overall survival and disease-free survival at 1 year, 3 years, respectively. So what to do after transplant? Monitoring chimerism is extremely important. It should routinely be performed post-transplant in blood and marrow samples for surveillance of engraftment. It provides a valuable tool in prognosticating survival outcome after transplant by predicting relapse rate. Rate of change of chimerism may be more important than chimerism status, or absolute percentage of chimerism for predicting outcome. Rapidly decreasing donor chimerism or mixed chimerism early post-transplant may be indicative of imminent relapse. So how can we prevent any relapse? So preventing relapse, the strategies, couple of the strategies, one is the chemotherapeutic, which means azacitidine, maintenance post-transplant to prevent early relapse, or prophylactic donor lymphocyte infusion is another strategy to prevent the early relapses. those who relapse after transplant, what should be the treatment? Hypomethylating agent alone or in combination with VDLI. Azacitidine is the most studies of the two hypomethylating agent, but retrospective studies show that decitabine may be an acceptable alternative to azacitidine. Therapeutic treatment of relapse, therapeutic DLI can still be considered without the signs of GVHD in these patients. And alternatively, a second ADO transplant may be considered for these patients. So moving on to the second indication for allogeneic transplant given to me is chronic myeloid leukemia. This is the historical data, almost 35 years old, where in those days, the probability of survival was around 60% at 2 years. And then you have a flat curve, whether you are doing transplant for first chronic phase or second chronic phase. But the story is not that rosy. Accelerated phase or the blast crisis, when the transplant were done in those two stages, the long-term survival is less than 20%. So this was pre-imatinib era. Certainly, this data was published in Annals of Internal Medicine in 1986, when the transplant, allogeneic transplant, was in perhaps the second decade of its life. So what are the indications for transplant in imatinib era? If you are seeing a patient with chronic phase, failure of first-line TKI and predicted poor response to second-line TKI is one indication to select for early allogeneic transplant. Failure to respond to first and second-line TKI should be considered for transplant. And if you've identified T315I mutation and or failure to respond to ponatinib, these patients should be transplanted as early as is practical and possible. What about patients who presented in accelerated phase at the outset, and they are TKI naive? TKI naive with suboptimal response to TKI should be taken to transplant straight away, should be sent to the transplant team to perform as early as this is possible. Blast phase, patient in second chronic phase after TKI or chemotherapy salvage should be considered for transplant, but I must admit that accelerated phase and blast phase transplant, the outcome is not that exciting as those of chronic phase chronic myeloid leukemia. Now, I would like you to focus on the data of allogeneic stem cell transplantation versus the drug treatment, especially the TKIs, early data. And this data, you can see here, it was published in 2007, and this is the first 5 years of data of utilizing imatinib or interferon hydroxyurea combination. And what you can see here, that what happens here, match related donor, match unrelated donor in chronic phase, MUD, accelerated phase, blast crisis. And if you compare, if you see these patients, the overall treatment-related mortality for these patients was about just under 30%. If you are doing match-related donor transplant, if this is an unrelated donor transplant, the treatment-related mortality was still around a quarter of all patients they died in this particular one. And not available was the AP and the blast phase data. Treatment-related mortality was not available for this group of 360 patients, interferon hydroxyurea and imatinib. What is the result of first 5 years of use of imatinib? 91% patients were alive at 2 years, 60% at 5 years, and 40% at 8 years. And 32% were predicted to be alive at 10 years. And what about allogeneic transplant with related donor? 76% of the patients were alive at 2 years, 62% 5 years, 56% at 8 years. So overall, what was the hint here? That the medical treatment, non-transplant treatment, started to show that is giving you a better overall survival and disease-free survival here. So this actually changed the practices of transplant and in favor of TKI treatment as compared to the allogeneic transplant in chronic myeloid leukemia. So allogeneic transplant is study outcome based on donor type. What you can see here, that again, this is an early data of when comparing the match myeloablative donor transplant versus reduced intensity transplant, matched sibling donor transplant, matched related donor transplant, and this is EBMT data, and then unrelated, unmatched related donor transplant, mismatch, unrelated donor transplant. And here, the overall survival at 2 years in all these cases was 68%, 49%, and 53%. Very short follow-up of only 2 years. And treatment-related mortality certainly was unacceptably high of matched sibling donor transplant, 25%, 40% and 37% respectively for related donor transplant and unrelated donor transplant. So all in all, a transplant for chronic myeloid leukemia, it used to have an unacceptably high treatment-related mortality, and overall survival was roughly in the range of 50 to 60%. So this has changed our direction to non-transplant treatment for chronic myeloid leukemia. One specific group of chronic myeloid leukemia who developed T315I mutation. These are the one who, if did not show the second-line therapy with newer TKI or homocytaxine, then should be transplant should be considered for these patients. In the case of T315I mutation, patient may consider ponatinib, homocytaxine, and arrow transplant, or one of the clinical trials available. A retrospective trial of CML patient with T315I mutation compared outcome of arrow transplant. No phase 3 randomized trial exists at this time. Overall survival at 48 months favored ponatinib for chronic phase chronic myeloid leukemia with this mutation, was not different for accelerated phase CML, and favored allogeneic transplant for blast crisis. So what happens when we use myeloablative conditioning versus non-myeloablative conditioning? The myeloablative conditioning certainly increases the risk of treatment-related mortality and lesser relapses as compared to non-myeloablative conditioning, where treatment-related mortality was far low, but relapses are far more. So there is you have to weigh which particular type of conditioning you want to give to these patients. Now, stem cell transplant data from Pakistan, very early data. It was published locally in 2008, and it was hardly, it's a small case series of about 37 patients. And what happened here, this was done at the Armed Forces Bone Marrow Transplant Center. And this is the survival curves, Kaplan-Meier survival curve of these patients, standard risk and high risk. Standard risk patient did very well with a survival, 5-year survival reported to be around 80%, as compared to high risk patient, which was about 50% survival. So coming to the end of my presentation, the tolerance, progression, cumulative toxicities, and cost limit the utility of TKI in chronic myeloid leukemia. As far as myelodysplastic syndrome, age, disease status, and availability of and the type of donor, they are the points to be considered for selection of patient performing bone marrow transplantation here. The current outcome of transplant for chronic myeloid leukemia in first chronic phase are excellent, certainly far better than the data reported by Donald Thomas in 1986. Transplant should be considered after failure of 2 TKI drugs, and for patients who are intolerant to TKI and patient in accelerated phase of blast crisis. For younger patients in our population, relapse occurring after allotransplant is amenable to DLI, TKI for finite duration, and interferon therapy of finite duration. For myelodysplastic syndrome, certainly we see younger population of diagnosed with myelodysplastic syndrome. The age group where in the West more and more chronic myeloid leukemia and myelodysplastic syndromes are seen and treated. Luckily, our population dynamics does not bring that population group to us, and still almost all centers focusing more and more on benign hematological disorders. So I think as our population ages, we will certainly next 10 years or so, we will see more and more patients with hematological malignancies, both acute and chronic myeloproliferative disorders and myelodysplastic syndrome for transplant. Thank you very much indeed for your attention, and I'll be more than happy to reply to any queries if you have. Thank you.
Thank you, Dr. Tahir Shamsi. Now we have our last speaker, Dr. Talha Munir. He's a consultant hematologist in St. James's Hospital, Leeds. He's a graduate of King Edward Medical College, Lahore, Pakistan from 2002. He's worked and trained in the UK in the NHS. He is a sub-investigator for the NCRI CLL phase 2 and 3 clinical trials in the UK and is involved in multiple NCRI and non-NCRI studies at Leeds Teaching Hospital. His main clinical and research interests are in CLL and the management of patients with aplastic anemia and paroxysmal nocturnal hemoglobinuria, and he's one of the PNH consultants working in the PNH National Services Leeds. He has a special interest in management of adult histiocytic disorders, especially Langerhans cell histiocytosis and Erdheim-Chester disease. I would like to invite Dr. Talha to start his talk on the chronic lymphocytic leukemia in 2020-21.
Assalamu alaikum. My name is Dr. Talha Munir. I'm a consultant hematologist at St. James's Hospital in Leeds, UK. Many thanks to the faculty of Shaukat Khanum Cancer Hospital who arranged this symposium, and I'm thankful to Waqas Vaid to ask me to do this talk. I'm a graduate from King Edward Medical College and been working with a lot of colleagues that are part of the faculty as well. So my job today is to talk about CLL in 2021. These are my disclosures. So what is CLL? CLL is chronic lymphocytic leukemia. It impacts a significant number of patients worldwide, but the most important thing is that it is the most common leukemia in the Western world. The median age of diagnosis is 72 years, with 90% of the patients being diagnosed above the age of 55. Men are twice likely to develop CLL, but 4 out of 5 patients are asymptomatic at disease diagnosis, which is important to recognize. With that perspective in mind, for the most important thing is when we are treating CLL, the most important question is what we want to do with the patient. What is the goal of the treatment? Is that improvement in symptom or quality of life, or is it disease control? Or you want to give protracted treatment-free interval to the patients. And eventually, you want to prolong the survival of the patients, as well as thinking about cure in some small number of patients. And what influences that choice? Obviously, comorbidities, what is possible in that patient, what does the patient want as well, and what treatments patients has had, and what about disease biology as well, and what is available in that part of the world where the treatment is being given, and what are the future options. So whenever I treat see a CLL patient, normally you know that 80% of the patients are not going to need therapy. So the important thing to remember is the patients have got hypogammaglobulinemia and T cell dysfunction. So this good advice needs to be given for infection from infection perspective. Then autoimmune complications, including ITP or autoimmune hemolytic anemia, is seen in about 10% of the patients, and that is something that needs to be counseled about. And there is good evidence that due to T cell dysfunction, there is a high risk of developing other cancers. So screening programs and participation in that is important. And that is what normally counts as a session will look like, with risk stratification of the patient. I would advise about health screening. Skin examination is important because patients are 6 to 7 times more likely to develop skin cancers. Vitamin D deficiency, which is related to chest infections, could be an important factor and may need replacement, and something about the cancer screening process, which I talked briefly about. But then there are questions about infection prevention. So high-dose influenza vaccine, I must say COVID vaccination now. Pneumonia vaccine, usually Prevnar followed by Pneumovax, is important. Should avoid live vaccine, but the Shingrix vaccine is allowed for these patients. And the patients who get recurrent infections can have intravenous immunoglobulins. But I think the treatment decisions are guided now by cytogenetic features as well as molecular features, which I will talk about. So the most common abnormality that we see in CLL is 13q deletion, but the important ones are placed here, like 17p deletion, 11q deletion, or complex karyotype. Out of which I would argue that 17p deletion is the most important one, where patients lose the short arm of chromosome 17. But then there is more data on IgHV status on the CLL surface, and unmutated patients do worse as compared to the mutated patients with chemoimmunotherapy. And then there is much more data on the genetic sequencing that's coming through. So on the short arm of chromosome 17 is this TP53 gene. And if you look at the deletion, you will find that in about 5 to 10% of frontline patients. But then if you go for the mutation analysis, then with Sanger, you can go up to 14%, and with NGS to 16%. So that you can have 30% of the patients who might be harboring this mutation or deletion at a very low frequency sometimes. But I think the most important message is that the deeper you go, the more you will find. And it is important because the new treatments do work very well for these patients. What about IgHV mutated status? So we know a third of the patients have got mutated CLL, whereas unmutated CLL in 2/3 of the patients, and they do badly with chemoimmunotherapy. And this is the outcomes for these patients. But you can see that in mutated patients, not every mutated patient is the same. So for subset 2, the outcome is is worse as compared to subset 4 or subset 1. So I think it's important to recognize that these things will become more important. So I think important to look out for these things, but then there is a whole host of other genes which are mutated in CLL, and they've got different level of influence in the outcomes for patients with CLL. What I'm trying to say is that CLL is not a straightforward disease now, where we've got a lot more to look out for apart from TP53. And primarily the biology of the disease and understanding has got better because we've got new molecules to treat patients with CLL. The common pathways that we used to use, like chemotherapy or radiotherapy not used in CLL, causes the activation of TP53, which causes the activation of pro-apoptotic pathway. So if you do not have TP53, this chemotherapy is unlikely to work. Then we've got surface markers on the cell surface like CD20, and monoclonal antibodies like rituximab or obinutuzumab or ofatumumab are very good options for these patients. But then we have old antibodies like Campath blocking CD52, or CD19 antibody like tafasitamab, which works quite well for these patients as well. But there are two pathways which have become the cornerstone of the change of treatment in CLL. And first one is the B-cell receptor pathway. We know that the B-cell receptor pathway is very important in B-cell signaling, and that is primarily transferred through coherent different kinases, one of which is BTK or Bruton tyrosine kinase. And ibrutinib was first in class BTK inhibitor, which blocked this drug and was a game changer. The other pathway is the PI3 kinase pathway, and idelalisib was first in class drug to block this pathway, and both resulted in improvement in outcome for patients with CLL. And then we've got this new drug, another drug called venetoclax, which is an inhibitor of, it blocks the BCL2 protein, which is an anti-apoptotic protein, and causes the release of pro-apoptotic factors to cause apoptosis. And that's the other drug which has actually changed the outcomes for CLL patients. If you go to any CLL talk, there are two concepts emerging in the management of CLL. One is continuous indefinite therapy, and the second one is fixed duration therapy, which we are used to because chemoimmunotherapy is a fixed duration therapy. But then there are two approaches that are being looked at. One is the MRD-driven approach and a defined duration therapy, and I'll talk about that in a bit more detail. So in terms of the frontline treatment of CLL, we normally would check IGHV mutation status for all patients. That usually tells you the time to first treatment. But when the patients are symptomatic and requiring therapy, checking for TP53 mutation or deletion of 17p is the most important test. And then the pathway is divided into if you've got TP53 abnormality or not. And the main difference is that patients who do not have a TP53 abnormality can have chemoimmunotherapy. And that depends on the fitness of the patient and whichever flavor of treatment you want to use. But now I will show you the data that the Bruton tyrosine kinase inhibitors have changed the outcomes in these patients, that chemoimmunotherapy might become obsolete as leads in West. And then venetoclax with the venetoclax, and I'll show you some data. Whereas for 17p deletion or TP53 abnormality patient, both PI3 kinase and BTK inhibitors can be used, or venetoclax with the venetoclax can be used. So if you look at the chemoimmunotherapy data, FCR is the commonest treatment used for fit patients. And you can see that this addition of rituximab as compared to FC backbone is better. Their 5-year progression-free survival in mutated CLL patients was excellent. It was 67% as compared to 33% in unmutated IGHV patients. If we look at the main benefit that is coming in the mutated IGHV patients, the next trial which was done was looking at patients who were fit, but they were looked at whether FCR, whether bendamustine rituximab is as good as FCR. We know that patients, not everybody can tolerate FCR, especially the patients above the age of 65. And the data was intriguing. It was clearly that FCR was better than bendamustine rituximab in terms of progression-free survival, but above the age of 65, that difference was not reached and p-value was not significant, and primarily because of the infective complications with FCR. What about if we use the gentle chlorambucil therapy in combination with the benitumumab or rituximab? This is the data from CLL10 study. And what you can see here that the median PFS was increased by a year if we use the type 2 monoclonal antibody benitumumab. But the important thing is the time to next treatment was 51.1 months, which means that if you give somebody this treatment, they won't need another therapy for nearly 4 to 4.5 years. So in a 72-year-old, that is not a bad thing. Then we come to the continuous therapy in the frontline setting and using a BTK inhibitor as compared to chemotherapy, which was chlorambucil. This is RESONATE-2 data, first trial to look at the option of BTKI inhibitor versus chlorambucil. And you can see that up to 7-year follow-up data, you can see that the median PFS for ibrutinib arm, single drug, 420 milligrams once a day, has been more beneficial as compared to fixed duration chlorambucil. And the interesting thing is that the benefit is seen in unmutated and mutated IGHV patients, which is different to chemotherapy. And then there are a host of other trials looking at the question. This is ibrutinib alliance data looking at ibrutinib or alone or in combination with rituximab versus BR. And clearly the advantage was in the ibrutinib containing arms. If you look at eliminate data, which is combining ibrutinib with obinutuzumab versus chlorambucil obinutuzumab, the short follow-up, the median PFS is again in favor of the ibrutinib-containing arm. And then we look at the fit patients, and this is data from ECOG 1912 study, FCR versus ibrutinib rituximab. And you can see that the main benefit of ibrutinib is in the unmutated IgHV patients, whereas the FCR patients for mutated IgHV disease are pretty much the same. So clearly showing that continuous ibrutinib or BTK inhibitor in frontline setting is beneficial. What about second generation BTK inhibitors? This is data from Elevate-TN study looking at acalabrutinib with or without obinutuzumab versus chlorambucil obinutuzumab. And the acalabrutinib containing arms at a median follow-up of 4 years is far superior as compared to chlorambucil obinutuzumab. What about TP53 deleted cohort? And this is just looking at the TP53 deleted patients treated with ibrutinib. The treatment naive patients, only 34 patients, but you can see that even at 5 years, the median PFS is not reached, and the estimated PFS is around 80%, which is unheard of in TP53 deleted CLL. There is more data on another second generation BTK inhibitor called zanubrutinib. This is the CQUA trial, looking at zanubrutinib twice a day, continuous therapy as long as the patient are responding. This is a short follow-up, but again, showing the benefit of using a BTKI inhibitor in frontline setting. What about fixed duration venetoclax with obinutuzumab? This was CLL-14 study. This is previously untreated CLL patients who are above the age of 65. So elderly patients were randomized 1-to-1 between receiving 12 cycles of venetoclax with obinutuzumab or 12 cycles of chlorambucil with obinutuzumab for 6 cycles. Investigated assessed PFS was the primary endpoint of the study, and the upshot of the study was that the estimated PFS after 12 months of venetoclax obinutuzumab, everybody stopped at this point, was around 74%. So 3 out of 4 patients have not progressed after stopping therapy, whereas for chlorambucil obinutuzumab arm, it was 35.4%. There is neutropenia and some tumor lysis seen in this combination, but the neutropenia does not translate into febrile neutropenia, which is what we worry about. But it is a very strong combination fixed duration therapy. There is more data coming out of combining ibrutinib with venetoclax, and this is the data from GLOW study, which is clearly showing that ibrutinib plus venetoclax in elderly patient was tolerated well. This was given for 15 months, and the IRC-assessed PFS was superior as compared to chlorambucil obinutuzumab. So I think to conclude, for frontline treatment with CLL, all phase 3 trials show that the target therapy, either BTKI inhibitors or venetoclax, was better than chemoimmunotherapy in the frontline patients. If you have to decipher further, the unmutated IgHV patients or TP53 disrupted CLL, definitely targeted therapy is better, but not for, at the moment, there is not a long-term follow-up to say that it would be better than mutated CLL. And for mutated CLL patients, ven plus obinutuzumab may be a very effective option. And the current trials are looking at doublets and triplets to see which is the best option for these patients. That takes me nicely to the treatment of a relapsed and refractory CLL. These are the same options, and I will go through the data again. So this is chemoimmunotherapy in relapsed refractory CLL. The most common combination is bendamustine rituximab, and that was showed a median PFS of nearly 1.5 years, whichever trial you look at, whether it was Murano trial, whether it was used as a standard arm, or Gilead 115 or Helios study. Everybody was showing the same results of median PFS of nearly 1.5 years. And then came along ibrutinib. This was first in class. This compared to ofatumumab in the relapsed refractory CLL, and the median PFS was 44.1 months as compared to 8.1 months with ofatumumab, and that led to the approval of this first in class BTKI inhibitor. Then along came alongside that, there was a PI3 kinase inhibitor called idelalisib, which was compared to rituximab in relapsed refractory CLL, and median PFS was in favor of idela rituximab. The problem with the idelalisib is that it causes autoimmune complications in form of colitis and hepatitis 6 to 7 months into treatment, and the drug has gone out of favor, especially due to that side effect. The ASCEND trial was looking at BTK inhibitor versus idelalisib rituximab PI3 kinase inhibitor or chemoimmunotherapy in the form of BR. And clearly the BTKI inhibitor, due to tolerance, is much better as compared to the other two options. Now we've got more data on comparison of head-to-head between the first-in-class BTK inhibitor, ibrutinib versus acalabrutinib. These patients have had 17p deletion or 11q deletion, and the primary endpoint was PFS. And the outcome of the data is that both drugs are equally effective. There is no difference in outcomes in terms of median PFS, but you see more atrial fibrillation and cardiac toxicity with ibrutinib as compared to acalabrutinib. You get more headache and cough with acalabrutinib, and with ibrutinib, you see a bit more arthralgia. So, and there were fewer discontinuation in the acal arm. So clearly non-inferior drug as compared to ibrutinib and with less side effects. Similar to that, zanubrutinib has been compared to ibrutinib, and again, you see that the overall response rate is better in favor of zanubrutinib. But the most important thing is the low rates of atrial fibrillation with this molecule. The problem with this trial is that it has got a very short follow-up. What about using venetoclax in relapse settings? So this was Murano study. This was relapse refractory CLL patients stratified by 17p deletion. They had 5 weeks of venetoclax titration and then 2 years of therapy versus bendamustine rituximab. Investigator assessed PFS was the primary endpoint. This has been followed up, and now at 5-year follow-up data, you can see that the median PFS is reached in the Ven plus R group, which is 53.6 months, so 2 years of therapy, and then the patients most probably would not need another therapy for nearly 2 to 3 years. That has led to an overall survival difference, which is very important in CLL, clearly in favor of Ven plus R. Again, TLS and neutropenia were the risks associated with it, but it's tolerated very well. In relapsed refractory CLL, the targeted therapy is clearly showing a PFS advantage as compared to chemotherapy. Now we've got more data on the second generation BTK inhibitors, and they appear to have less toxicity. And fixed duration venetoclax with obinutuzumab is better than chemoimmunotherapy. There's no head-to-head comparison between BTK inhibitors and venetoclax rituximab. What are the options after that? Now we've got non-covalent BTK inhibitor called LOXO305, or it's got a name pirtobrutinib. This was used in patients who have acquired a cysteine 481 mutation. That's where ibrutinib or acalabrutinib binds to. And in this group of patients, the response has been pretty good. Short follow-up, where the patients have been doing well. This data there is another molecule called ARC-531 where it has been looked at. Allogeneic transplant in novel agent era, the main outcome from this study was that small number of patients who had allogeneic transplant, the number of novel agents or specific novel agent didn't make a difference. The same things like comorbidity index and donor selection was the most important factors. What about CAR T cells? So this is a product called Lysocell. This was used on its own or in combination with ibrutinib in very high risky patients. And the median follow-up is short in these patients. They do respond, the patients do go into MRD negativity, but the bulk of the disease is important. If you add ibrutinib, you get less CRS and you get less neurotoxicity, but these are very small number of patients, and the long-term follow-up data is being tested. In short, chemoimmunotherapy is tried, tested, it's long-term data, fixed duration, and maybe the cheapest option. It might not be suitable for everyone and can cause stem cell damage. BTK inhibitor, very good data now in frontline setting and relapse setting, but it is continuous therapy. We know that the cardiac toxicity is a problem and drug-specific mutations could develop. When venetoclax in combination, usually fixed duration, is very good. And again, cost and practical issues in delivery is important. So what I would stop with really is showing you this slide that CLL is a rapidly changing world. Till 2010, we didn't have many options at all. And now in the last decade, it has just exploded and we've got so many molecules. Previously, we used to just diagnose patients based on morphology, but now we've got flow, FISH, Sanger sequencing, and doing NGS and whole genome sequencing, as well as epigenomics in these patients. So I will stop there and I will take any questions. Many thanks for listening and many thanks again for inviting me.
Thank you very much. We have 10 minutes for questions. So we would like to take a few questions. Do we have all our panelists here? Yes, we do. Professor Charlie, is he here?
Yes, I think if all the panelists can unmute and start their video as well, that would be great.
Okay. Professor Charlie, my first question is for you. It's a simple, basic question, but it'll be helpful to us. As you mentioned, we tend to transplant. We try to take to the AML patients to transplant everybody who's high risk, and those that we can take in intermediate risk. But we do get some patients because of lack of unmatched registry here. If you have a patient who has an NPM positive AML, and if we cannot transplant, we obviously tend to monitor, but how long would you monitor? Would you monitor till they relapse, or what would be your approach be for such patients?
Well, it's a tremendous question. And first of all, I want to say what a pleasure it is to be here. And I've just listened to Tal's fantastic talk, which is a wonderful bonus on a Sunday morning. And also, I'm wishing Pakistan every good wish in the upcoming World Cup final against England. And if you lose because of a Jos Buttler century, don't feel too bad about it. But it's a great tournament and a real celebration of the greatest game in the world.
Yeah.
So the answer around NPM1, I think you're absolutely right. There is a risk stratification after 2 courses of intensive chemotherapy, and you can do that on peripheral blood PCR. And if patients have a greater than 3 log reduction, they should not proceed to transplant. The question about monitoring is actually a very interesting one, because you could say that that in itself is sufficient and you don't need to sequentially monitor. But if you do have the capacity to sequentially monitor, our practice is 3 monthly up to 2 years post-transplant, speaking to the kinetics of relapse after chemotherapy. And the great majority of people, if they're destined to relapse, will do so within 2 years.
Okay, thank you.
Prof. Charlie, I have a related question. This is Wakas here. With the Figaro trial that was conducted under your guidelines, we know that the MRD positivity and MRD negativity has become quite important before transplant, because that was the first time showed in a prospective way. So in your practice, do you actually target achieving MRD negativity prior to their transplant? Do we hit them really hard with stronger chemotherapy as we did in AML 17 trial, or?
Yeah. So I think it's a tremendous question, Wakas, and we miss you very much. We hope we might see you over Christmas. I think in my judgment, the most important curative strategy in high-risk AML is an allograft. And the graft versus leukemia effect is extraordinarily effective. 40% difference in relapse rate, according to cyclosporin level post-transplant. So I think what you try to deliver is a curative therapy, and that's the graft versus tumor effect. There is no randomized data that in patients who are MRD positive, they benefit from another course of chemo that may compromise their ability to go to transplant. And my view is that if people are in a morphological remission, this is supported by the Figaro data, with a MAC or a RIC, although your relapse risk is a bit higher, your survival's a bit less, it's still not bad. So I think if you're in remission, you should go to transplant, get on with it. The transplanter might wish to think about tweaking the regimen so you optimize the graft versus tumor effect, tapering cyclosporin earlier or something like that. But my view, Wakas, at the moment is it's a mistake to give repeated courses of chemotherapy to try and get people into MRD negativity. We don't know whether it's of any benefit at all. It may well be of harm.
Okay, thank you. Professor, there's another question, not entirely transplant related, but induction of AML, we do see a potential shift of induction from DA3+7. In fact, that's for the elderly patients with venetoclax and AZA plus minus FLT3 or a third agent. But do you see this in younger patient group?
Yeah, I think it's a tremendous question. There's no doubt in my mind that the combination of venetoclax plus azacitidine, and possibly there's some very promising data with a triplet, venetoclax, azacitidine, magrolimab, that randomized studies now need to be performed to ask whether there's particular populations will benefit. And in my judgment, in brief, there are two populations who are likely to benefit. One is people with inherently good risk disease. So in the UK NCRI group, we have a study called Victor for older patients who'd otherwise get intensive chemotherapy or NPM1 positive to randomize with a venetoclax-based regimen versus DA. This may well be a curative therapy in this population in a significant proportion. Alternatively, in high-risk patients, the strategy there is to get to allograft, and all you want really is to get into a morphological CR with minimal toxicity. And there, I think it's very plausible that a ven-based regimen may be better than DA. We need randomized data to support it, but I have no doubt that we're going to be breaking down the population of patients who conventionally get DA. I think at the moment this is experimental, and the standard of care remains DA. These are two very exciting areas.
Thank you.
Yeah, I have a question for Dr. Iram Khan and Dr. Tahir Shamsi as well. For a young patient with, let's say, intermediate 2 or high-risk MDS, would you proceed with an allogeneic transplant straight up, or would you give chemotherapy or hypomethylating agents beforehand? As Professor Tahir Shamsi mentioned in his talk, that allo transplant remains the only potentially curative treatment for MDS. So Dr. Khan, your views?
So yeah, thank you. That's a great question. We still argue about this in our transplant meetings, but I think that there is enough data to suggest that blast count at the time of transplant does correlate with risk of relapse. So I think that getting that blast percentage down to well below 10%, as close to normal as possible, or less than 5%. And so generally the least toxic route to do that is probably, because again, sort of your big player is going to be the transplant. And so kind of minimizing the toxicities of intensive chemotherapy, given that, we sort of have data that hypomethylator versus intensive chemotherapy in MDS may be sort of neck to neck. We generally lean toward hypomethylator in the high blast count, but there are some patients for whom you could argue that intensive chemotherapy in a young patient would be reasonable, possibly quicker, possibly a deeper remission if you use single agent HMA. But now with venetoclax, it's hard to say. But yes, getting the blast count down and probably lean toward HMA.
Yeah. Thank you, Akash. Thank you for this question. I think it's a very pertinent and important question to be asked in myelodysplastic syndrome patient, especially in our population, younger population in their 40s and maybe early 50s. Somebody presenting with a high blast count certainly require, if he's fit enough, certainly require chemotherapy to bring the blast cell count down to less than 10%, maybe 5% if you're lucky. Otherwise, if to start with blast count are not that high, hypomethylating agent, or if a patient is not not in a good shape, then certainly hypomethylating agent may do the trick to bring the disease under control, so that the post-transplant relapses may be able to get a lesser number of relapses if the blast percentage at the time of transplant are less. So more or less my answer, I concur what Dr. Iram Khan has already said. This is exactly what we discussed in our transplant meetings for myelodysplastic syndrome patients.
Many thanks, Dr. Tahir. We don't have many questions for CLL, unfortunately, but I have one.
Yeah.
Yes, Dr.
Go ahead.
Shaukat.
I was going to ask Dr. Talha that you mentioned, you touched the MRD testing in CLL. Are we heading towards the era like in CML, in relapse CLL? If you have a patient with on venetoclax and Ritux and you keep monitoring the MRD and you stop the treatment and then you resume the treatment?
Yeah, so MRD is a very important question in CLL at the moment. And the primary reason for that is that whether you are able to stop therapy based on the depth of the remission. And the best test that we can do at the moment in order to tell us that information is MRD. The question in MRD is how do you do it? So if you use flow, you can go down to 10⁻⁴, up to 10⁻⁵, but with NGS now you're going down to 10⁻�6 and -7. So if your patient is able to achieve that depth of remission, the chances of their relapse are pretty low. For IGHV mutated patients, some of the patients might be cured if they reach that level. For unmutated patients, it's very likely that those patients will still relapse. So defining the duration of therapy based on MRD is a very hot potato at this moment in time in CLL. But the problem at this moment in time is that you need to standardize the MRD test. Most labs use flow cytometry, whereas the NGS is based on one platform and they have got a bit of a monopoly on that. So it's very expensive. But all of these questions are being looked at in trials at the moment to see whether we will define. In the UK, all of our trials are MRD-based trials, where we are defining the duration of therapy based on achievement of deeper remission. And I think that is where the world is going at the moment. And hopefully that will define which patient is a low risk, medium risk, or high risk.
Okay. Thank you very much. With this, we'll conclude our session. I'd like to thank all the speakers, Professor Charlie, Dr. Iram Khan, Professor Shamsi, and Dr. Talha. Thank you very much for giving us your time and extraordinary talks.
Thank you.
Thank you.
Thank you.
Take care.
Bye.
Enjoy the final.
You too.
You
Thank
too.
you.
So welcome back, everyone, to the second session on hematological malignancies. So this session is going to cover lymphomas and plasma cell neoplasms. We have 4 great talks by our presenters. So I'll ask Dr. Osman to introduce our presenters. Over to you, Dr. Osman.
Thank you, Dr. Waqas. So again, welcome. So we've got our first speaker is Dr. Christopher Fox. Dr. Christopher Fox is a consultant hematologist at Nottingham University Hospitals, where he is the lymphoma MD chair and CLL research lead. He has received a PhD from the University of Birmingham for research on EBV lymphomagenesis. He is currently honorary associate professor in University of Nottingham. He is a current chair of UK NCRI lymphoma high-grade subgroup. He also co-leads UK CNS lymphoma working group. And today he's going to be talking about CNS lymphoma, current state of the art as well. He has his clinical research interests include rare and challenging lymphomas such as CNS lymphoma, T-cell lymphoma, and post-transplant lymphoproliferative disorders. So over to Dr. Christopher Fox about CNS lymphoma, current state of the art treatment.
Hello, and thank you to the chairpersons and organisers for the opportunity to speak today at your symposium on the topic of primary central nervous system lymphoma. My name is Chris Fox. I'm a haematologist in Nottingham in the UK, and I lead the UK's NCRI research study group for aggressive lymphomas. These are my conflicts of interest. So let's start with some basic epidemiology. And for the purpose of the next 25 minutes or so, I'll be focusing purely on primary central nervous system lymphoma of diffuse large B-cell lymphoma histology, as defined by the WHO. And histopathologically speaking, this group comprises more than 95% of primary CNS lymphoma. So this is a rare brain tumor, and it's a rare lymphoma. And in the modern era, most of the cases we see are DLBCL histopathologically, and the patients are immunocompetent. It's very unusual, certainly in the UK at least, to see HIV-associated tumours typically with very low CD4 counts and EBV-associated. They're certainly a small minority of cases nowadays. And the incidence appears to be rising, at least in data sets from Europe and North America. The incidence per year is in the order of 4 to 5 per million. And this doesn't seem to be simply explained by improved diagnostics. So the incidence of other brain tumours has not risen at the same rate. And we're also seeing this in older patients. You'll see from the literature that the median age is often quoted at around 60, but from a large national data set from France, the median age was 68. And from my own practice in the East Midlands, I'll show you some population-based data in a few slides. The median age was approaching 70 years old. And here we have just a figure from a recent paper we published in the British Journal of Haematology, looking at one aspect at least of the age at diagnosis over a 4-decade period going back to the early 80s up until 2020. And you'll see here illustrated on this dot plot the median age rising up to 70 years to the modern era. And of course, there are particular considerations when we treat primary CNS lymphoma. As lymphoma clinicians, we see aggressive lymphoma in many different anatomical sites with different physiological and pharmacological challenges, but there are unique challenges to treating this entity. There are the clinical sequelae, so the neurocognitive dysfunction due to the disease or complications of treatment, which can be acute or late. We also have the challenge of drug delivery to the central nervous system. And even one of our most important drugs, high-dose methotrexate, only has a very limited, relatively limited penetration through the blood-brain barrier into the brain parenchyma when compared to a ratio of the same drug in serum. And of course, we also have a very important consideration that the brain tissue is highly vulnerable to any insult, which includes treatment-related toxicities. And we need to be very mindful of this when we are delivering therapy to these patients. And it's important to consider primary CNS lymphoma as a whole brain disease. Even with highly sensitive MRI imaging with gadolinium contrast, a unifocal lesion or multifocal lesions should always be viewed circumspectly, because at post-mortem examinations, we often find, or nearly always find, that the disease is present in all other sites of the brain as microfoci. And you'll see here on the middle photomicrograph the typical histopathological appearance with the perivascular distribution of the B cells, and quite a rich tumor microenvironment, not shown here, but often there are infiltrating T cells as well as other antigen-presenting cells. So we feel that the microenvironment is important for pathogenesis, but the contribution has not been well delineated yet. And the standard of care in terms of diagnosis is a stereotactic biopsy, image-guided biopsy, which unfortunately only yields very small pieces of tissue, as you can see here, which is usually sufficient for diagnosis, as long as we've avoided steroids before the biopsy. But as you can imagine, it will present quite a big challenge to biological research. So, and this really lags behind the systemic counterpart of DLBCL in terms of understanding the genomic and mutational landscape. And I won't have time to go through pathophysiology and the biology in much detail to say, but at least to say that certain mutations we know are very common, MYD88 in probably 2/3 to 3/4 of cases, and often that coexists with mutations in CD79B. So the B-cell receptor pathway is clearly important. There's also evidence biologically of immune escape mechanisms, and that might speak to the sanctuary site location of this tumor. And the biology is clearly distinct from systemic DLBCL. So we can see both in genomic and transcriptomic readouts that this is a distinct pathobiological entity. Moving back to clinical data, these are population-based data from our own region in the UK, the East Midlands, where Nottingham sits. And we have a database stretching back 4 decades, as I showed you the age data a few slides ago. And this is just a comparison, an era-by-era retrospective comparison of how outcomes have improved for patients with primary CNS lymphoma over this period, taking a cutoff 10 years ago when our treatment paradigm changed. And we moved to initially high-dose methotrexate and high-dose RC based treatment, evolving into the matrix protocol that I'll talk about in a few minutes, and significant change in practice away from whole brain radiotherapy and towards high-dose Thiatipa based autologous stem cell transplant as consolidation. But you can see here, nevertheless, that despite the improvements in survival, there's still a significant proportion of patients who unfortunately fail treatment. And overall, this is probably about half of patients when you include consecutively diagnosed patients of all ages, and not just the fitter patients that go into trials. And why has why have treatment outcomes improved? Why has survival improved? Perhaps it is influenced by a number of factors. I think the speed of from diagnosis to treatment, the interval from diagnosis to treatment is really important. And our paper with first author Furqan Kaji there in the British Journal of Haematology relatively recently shows quite a clear improvement in survival for patients who are treated within 14 days of diagnosis compared to a longer diagnosis to treatment interval. We don't know for sure, but we feel like the improvement in survival may also be influenced by the more effective remission induction protocols and the increasing use of high-dose Thiatipa-based autologous transplant. And certainly that's supported by trial data that I'll show you in a few moments. So these are the updated data from the IELSG32 study, which is an international trial led by Andres Ferreri in Milan, in Italy. And we now have very mature data that he presented at the congresses earlier this year, the ICML Lugano and the European Haematology Association meetings, with more than 7 years of follow-up. And many of you may be familiar with the trial, the research questions in this trial. There were 2 principal questions. One related to the induction therapy, which remission induction regimen was the most effective in terms of overall response and complete remission rate. And this was compared to the backbone of high-dose methotrexate and high-dose RC, you see there on the left. Does the addition of rituximab improve response rates? And does the addition of both rituximab and Thiatipa, which is a small molecule lipophilic alkylating agent, it's very effective at penetrating into the brain parenchyma. Which of these is the superior regimen in terms of CR rate? The second question related to the consolidation therapy, which traditionally was whole brain radiation. And patients who responded to first-line treatment were then randomized in a 1-to-1 fashion to whole brain radiotherapy against Thiatipa and BCNU-based autologous stem cell transplantation. And these initial outcomes of both these randomizations have been published now a few years ago, and I'd certainly commend you to the 2 papers in the Lancet Haematology, published in 2016 and 2017, if you want to go into more detail. But in terms of the updated data, I'll just briefly show you some survival curves. So the purple survival curve on this Kaplan-Meier plot at the top is the regimen we now call Matrix, which was arm C in the ILSG32 study, which was the 4-drug combination, the 2 antimetabolites, high-dose methotrexate and high-dose cytarabine, the anti-CD20 monoclonal rituximab, and the alkylating agent diatepa. So very clear, early and clear separations of both the progression-free and overall survival curves, with significant and incremental benefit for the addition of rituximab in the middle curve, and the 4-drug combination that we now term Matrix as the top curve. And this is the 7-year follow-up data in relation to the consolidation arm. So you will remember that whole brain radiotherapy was the standard consolidation approach. High-dose diatepa-based autologous transplant was arm E, which was the experimental arm in this study. And actually, there was no difference in terms of progression-free survival or overall survival between these two consolidation arms. So whichever consolidation arm a patient was randomized to, their survival outcomes were the same. These curves focus purely on the patients who were randomized to arm C, who received the 4-drug Matrix regimen. So if you were randomized into the Matrix arm and you reached the consolidation phase of treatment, whether you had whole brain radiotherapy or autologous stem cell transplant, your outcomes were very good. And we can now tell our patients that if they proceed through Matrix and reach consolidation, and at least in the UK, we use the autologous transplant as the favored approach because that had less long-term neurocognitive deficits than whole brain radiotherapy, then a given patient would have a 70% chance of survival at 7 years if they proceed through consolidation. So certainly substantially better than historical outcomes in this disease. Nevertheless, despite these treatment improvements, and when you look across the different protocols that are used in Europe, on the left, France in the middle uses a slightly different induction protocol, but they do use high-dose diatepa-based autologous transplant for patients under 60. And then on the right, the North American, the Californian groups data using a slightly different high-dose chemotherapy consolidation without stem cell support. Whichever protocol you look at, you can see clearly that there's an unmet need very early in treatment. So a significant proportion of patients, probably around a third of patients who initiate high-dose methotrexate-based therapy will have a poor outcome in the early months or following treatment initiation. And clearly this is a big problem for us to solve despite improvements in therapy to date. And if you look at the ILSG32 study, and this is very similar to the other primary CNS lymphoma studies I've just shown you, the majority of deaths are unfortunately from disease. And this is probably explained by at least 2 different reasons. Firstly, the remission induction is failing. It's not, yes, it's more effective, but it needs improvement. And that's exemplified by the fact that only 62% of patients who were randomized to Matrix, the most effective arm in the trial, actually proceeded to consolidation. And some of that is explained by toxicity, some of it by progressive disease, some of it by failure to collect stem cells. But overall, a third of patients are not proceeding to the consolidation phase of treatment that we feel is very important in this disease. So that's clearly an area to address. We also have a problem with a proportion of patients, probably in the order of 20%, it seems, who experience relapse after consolidation. And that tends to be early, tends to be in the first 6 to 12 months after consolidation therapy, whether it's whole brain radiotherapy or autologous stem cell transplant. And there are 2, I'll just draw your attention to 2 randomized trials that have recently finished recruitment, and we've seen some early data, and the full data sets are expected soon, which are asking questions regarding consolidation with high-dose diatepa-based autologous transplant as the control arm, and non-myeloablative chemotherapy approaches, both in the German-led study, the ILSG43 study, and in the ECOG North American study. So asking a question regarding myeloablative versus non-myeloablative chemotherapy consolidation, rather than whole brain ready therapy, which doesn't feature in the intention to treat population. But of course, this doesn't deal with the first problem I show you on the slide, which is the deficit of remission induction. And so in order to try and optimize our current therapeutic approaches, together with our German colleagues, Gerard Illerhaus and Lizzie Schwab in Stuttgart and Freiburg in Germany, we've put together a new trial that we've termed Optimate, which is aimed at demonstrating the superiority of a modified and attenuated de-escalated remission induction strategy followed by autologous stem cell transplant. And I'll just briefly show you the details here. And again, this is for patients under the age of 70 with performance status shown there according to age for eligibility. And the standard arm is on the top, 4 cycles of matrix as per ILSG32, followed by thyroid-based autologous transplant. And in the experimental arm, you may be interested to see that patients are actually having less therapy. They're having a less intensive first cycle, and then they're having a more abbreviated induction regimen before being consolidated. And this really addresses a couple of problems that we've seen both in the previous trial data and in the real world setting. The first of which is that the treatment toxicity with matrix is quite considerable, mainly hematological and infectious toxicity, and that's largely loaded in the first cycle of treatment. So treatment-related deaths and significant toxicities that delayed treatment were most common in the first cycle, and that's almost certainly due to the patients having an impaired performance status due to their disease, and potentially because of considerable steroid doses that patients may be on at that time. So by de-escalating or attenuating the first cycle of treatment, aiming to improve performance status, reduce serious toxicities in that first cycle, and then proceeding more quickly on a shorter timeline to autologous stem cell transplant, which we think is really important in this disease for long-term survival. The hypothesis is that this will lead to significant improvement in outcomes, but also reduce the overall toxicity and treatment burden for patients. And so this is the primary endpoint, and some very basic detail on the sample size calculation shown there. The trial is now open in Germany and recruiting, and we just have the trial funded in the UK and hope to start recruitment early in 2022. A brief overview of the problem of older patients with primary CNS lymphoma. I've already said that the median age is approaching 70, and so therefore at least half of patients probably can't be treated with the intensive approaches I've described so far. We know that age is very important prognostically, and it's a continuous variable rather than being a binary cut-off parameter. And performance status is at least important, and certainly in clinical practice we see older patients who have a good performance status doing well, and conversely patients with younger patients even with a very impaired performance status at diagnosis have a much higher chance of treatment failure, and this has been validated across different series. Clearly, the older brain is more vulnerable to treatment-related toxicities, specifically a desire to avoid whole brain radiotherapy if we can in these patients. And on the other hand, older patients are often fitter now and have more physiological reserve and ability to withstand more intensive treatments. So many patients, even up to the age of 75, could be eligible for a more intensive approach, including stem cell transplantation. This is a protocol from the German Remain study, published now a number of years ago in the journal Leukemia, aimed at older patients who are not fit enough for more intensive protocols. This is delivering high-dose methotrexate every 2 weeks alongside rituximab, and together with the orally administered alkylating agent procarbazine, which is very well tolerated and has very little hematological toxicity over a 12-week period, followed by a 6-month consolidation or maintenance phase of procarbazine. And you see here that from the study that was published that the median age was 75, going up to 83. And these were the outcomes, clearly less good than the younger patients who have more intensive treatment. But for an older population, with perhaps 40% or so of patients free of progression at 2 and 3 years, these results are encouraging. Clearly lots of work to do, but certainly in the older patients, this is a protocol worthy of consideration. Some older patients, as I mentioned, will be eligible and sufficiently fit for a more intensive approach. And these are some data we published with other colleagues from the European nations a few years ago in the BMT journal. And you'll see here that these were older patients with a median age of 69 going up to the age of 77. And almost 2/3 of whom had relapsed primary CNS lymphoma, and the remaining patients had this as consolidation as first-line treatment. And considering the age of the patient, the disease, and the line of treatment, these are quite impressive outcomes, with certainly over half and perhaps as many as 2/3 of patients having good outcomes at this time point of follow-up. So certainly high-dose therapy with stem cell support using thiotepar conditioning. We use a lower dose of thiotepar conditioning for the older patients, 10 mg per kg rather than 20 mg per kg, and certainly worth considering for your older, fitter patient. In the real world, most patients are not, most older patients are not sufficiently fit for high-dose therapy. And this was a population-based study from the UK that we published last year in the British Journal of Haematology, showing outcomes by treatment intensity. And of course, this has inherent bias because the fitter patients are more likely to be treated intensively. But it does convey the message that if a patient is able to tolerate a high-dose methotrexate based approach, and particularly if they're able to tolerate high-dose thiotepar-based consolidation, then this certainly should be considered. So, and there was a dose relationship with methotrexate in this study, that the more cycles of methotrexate that could be delivered, the better the outcome. So within bounds of tolerability, we should be really treating our older patients where feasible more intensively. Of course, many patients do fail first-line treatment. We've discussed that already. And relapsed refractory primary CNS lymphoma is a really big problem. These are data from a French population-based study from a few years ago, but I'm sorry to say that outcomes have not really improved for this relapse group very much in recent years, and it's very similar to a curve you might see in relapsed T-cell lymphoma, for example, with survival measured in a small number of months, sadly. We did undertake a study in the UK to try and improve outcomes for patients with relapsed refractory primary CNS lymphoma, and this was published recently in the Blood Advances journal. But unfortunately, we were not able to make any substantial progress by incorporating thiotepar into the ifosfamide-based regimen that was previously published, RIE. So adding thiotepar to RIE was feasible, but with the exception of a very small number of patients who you see there on the plateau, who proceeded to autologous transplant as a second-line or third-line consolidation, the majority of patients did very badly, I'm afraid to say. And so a number of new agents have been developed, and you may have seen data from a number of studies from different territories aiming at trying to explore the biological basis of primary CNS lymphoma and use more targeted agents. BTK inhibitors have been used, namely ibrutinib, also tirabrutinib, very high response rates, a good biological rationale, but unfortunately very short duration of response for most patients. A very high response rate and short PFS. Similarly so for lenolidomide, which is being used as a single agent, but also in combination with rituximab in a French study. And certainly patients are, significant proportion of patients are responding to lenolidomide, and the T-cell repertoire may be important here. But most patients, despite early responses, will subsequently experience progression. So as single agents, these drugs probably are not the answer, and combinations may be attractive. Checkpoint inhibitors, nivolumab, has been used in a big global phase 2 study. No data has been forthcoming yet, and I'm not sure whether this is going to be as promising as perhaps first was anticipated. In the UK, we're just about to launch a study of the second generation BTK inhibitor zanubrutinib, initially in monotherapy to get safety data and pharmacokinetic and other data, with a view to rolling into combination studies of zanubrutinib plus another rationally selected drug. This may be an IMiD, this may be another targeted therapy that's relevant to the biology of primary CNS lymphoma. But I think this is the direction of travel that we need to go in for this difficult group of patients. Also of great interest, of course, are CD19-directed CAR T cells, certainly in systemic DLBCL and other B-cell systemic lymphomas. In this trial, led by my colleagues Claire Roddy and Kate Sinarski at UCLH in London, is a really pioneering pilot study to see if we can show both safety and efficacy of CD19-directed CAR T-cell therapy alongside checkpoint inhibition with pembrolizumab in the context of patients with primary CNS lymphoma who've relapsed after at least one line of prior therapy. I won't go through all the detail in this slide in the interest of time, but suffice to say, it's fairly standard lymphodepletion plus checkpoint inhibitor, followed by the Autolus sponsor CAR T construct, which has a very fast off time in terms of target occupancy. And so this trial is up and running, and a number of patients have already been treated. We eagerly look forward to seeing both safety and efficacy data in due course. So just to conclude, perhaps we can look to the future. We can first reflect back and say that we have made substantial progress in the treatment of patients with primary diffuse large B-cell lymphoma of the central nervous system. We should recognise that this has been largely achieved through the delivery of more intensive multi-agent chemoimmunotherapy approaches, including the use of autologous stem cell transplant. But I think it's fair to say that we are approaching the ceiling of progress using these largely empirical, uniform approaches. And I think in order to make future progress, we need to first optimize our current therapies. As I've discussed briefly, I think we need to refine more carefully risk stratification, both at baseline, but also dynamically during therapy. We know that patients' performance status can improve, and their ability to tolerate treatment and the quality of their response to treatment may be able to influence how we deliver treatment in this condition. I think we need a better understanding about the disease biology. We need to catch up with the genomic understanding that we now have for systemic DLBCL. And these data are essential in order to inform which therapies and how we integrate the newer therapies into the primary CNS lymphoma protocols. And certainly there are trials looking at adding the novel agents I mentioned, including the IMiDs and BTK inhibitors into frontline therapy combined with chemotherapy, and the French group have recently initiated such a trial. And lastly, I think we need to get better at measuring disease, even with high quality contrast enhanced MRI imaging. We are still insufficiently refined at measuring response to disease, and there was certainly some very interesting data using ctDNA, both in peripheral blood and in CSF emerging. And I think as this sensitivity and deliverability of this technology improves, this is something that we should be looking to inform our treatment in primary CNS lymphoma. And I'll stop there. I'll leave my acknowledgement slide here to thank a number of colleagues, funding groups and academic collaborators. I thank you for your time and attention.
Thank you, Dr. Fox. Very elaborative talk on CNS lymphomas. So we're going to move on to our next talk, and that's going to be by Dr. Farooq Wandro. He's a consultant hematologist, chemotherapy and MDT research lead in his department of hematology at Sandwell and West Birmingham Hospitals and NHS Trust. He's also an RC Path medical examiner, an honorary senior lecturer in Department of Immunology and Immunotherapeutics, University of Birmingham. He's also a senior academy tutor for Medical School Birmingham. He's going to be talking about recent advances in myeloma. So over to Dr. Farooq Wandro.
Hello, my name is Farooq Wandro. I'm a hematologist in Birmingham, UK. It's my great pleasure to be a speaker at this symposium of the Shaukat Khanum Cancer Hospital again. It would have been a pleasure to be there in person, but obviously pandemic didn't allow that. And I have uploaded some of the pics from my previous symposium and the visit to the Great City. Talking about myeloma, we have made a steady progress in the treatment of myeloma. If you can look at this chart, which shows that melphalan was the only modality of treatment till late 80s, early 90s, and the median survival used to be 2.5 years. But since then, with the introduction of high-dose therapy and autologous stem cell transplant in late 80s and early 90s, changed the survival to significant up to 2.5 to 3 years. And but it wasn't till year 2000 when the immunomodulatory drugs like thalidomide and proteasome inhibitors were introduced as in the algorithm that we actually saw some survival benefit. And this has continued since with the introduction of new novel agents, and also the results from the combination of these agents from different clinical trials has markedly improved the PFS as well as overall survival in both elderly as well as young myeloma patients. Now, the younger myeloma patients have a median survival of around 7 years, and the older myeloma patients and has also had a benefit with these new treatments that the median survival is now around 5 years. So we have made progress, particularly in understanding the biology of the disease. There have been obviously substantial improvements in the outcome due to availability of new effective therapies. And myeloma has now become a chronic disease in a majority of the patients. The challenges do remain. We still don't know how to treat the high-risk disease. We still don't know how to treat the bony disease. And myeloma does remain an incurable malignancy in majority of the patients. And invariably all patients ultimately relapse. And there's also issues with the symptom burden due to the disease, as well as because of the cumulative effects of the treatments. Therefore, when we're treating myeloma patients, we need to know the balance of disease control and matching that with the quality of life. So what has changed recently? The IMWG criteria in 2014 introduced 3 more variables to help in diagnosing myeloma, particularly when you have a smoldering myeloma, but you don't know when to start treatment. So if you have a clonal plasma cells in bone marrow more than 60%, serum free light chain ratio more than 100, more than 1 MRI lesion on the imaging, then that also confirms the myeloma in addition to the CRAB criteria, and that's in itself an indication for treatment. We also know that about 2/3 of myeloma patients will have a bony disease at some point, and bony disease substantially impairs the quality of life and is a major cause of morbidity and mortality. So most of the professional bodies now have recommended that low-dose CT or MRI or PET scan is a diagnostic modality or imaging modality of choice to detect the skeletal lesions, because we know the skeletal survey is not sensitive or specific to pick up the early lytic lesions. Therefore, we'll be missing lots of myeloma patients who will be so-called smoldering myeloma. And whereas we can see the sensitivity of CT, MRI, and the PET is quite high, nearly 100%. And therefore, many centers are using this modality of treatment, modality of imaging in detecting early disease, or also in follow-ups. There's also the revised ISS staging, which has also incorporated the high-risk cytogenetics, which consists of 17p, 414, or chromosome 1 abnormalities. And that helps in stratification or prognostication of the disease, although it may not really necessarily help us in deciding the treatment, because we don't know still what is the best treatment for high-risk disease. But it tells us that if you're RSS stage 3, when you have high-risk cytogenetics, then your 5-year survival is only 40% compared to 82% in the stage 1. So what are the drugs available now for the treatment of myeloma? As you can see, there are on the left side are the conventional drugs, which we are all well versed with, and we are using them, which consists of the conventional IMiDs and the proteasome inhibitors. And on the right side, we have a number of new drugs called anti-BCMA, which consists of CAR-T and the bispecific antibodies and novel antibody drug conjugates, etc. And we also have a number of monoclonal antibodies now in the clinical use. So how do we use them? Now, if we look at the results of all the trials which have used combination treatments up front, the triplet therapy seems to be doing the best. The combination of IMiDs and proteasome inhibitors gives the best overall response, as well as the partial response rates. Therefore, the current algorithm, depends on which country you're working in, consists of a combination of IMiD and a proteasome inhibitor in combination with dexamethasone, followed by autologous stem cell transplant and lenalidomide. That's a standard of care. Some people now recommend that for high-risk disease, we should use different modalities like carfilzomib-based treatments seem to be giving better results, especially on, looking at the results from the largest myeloma 11 trial. However, things are changing with the availability of anti-CD38 antibody like daratumumab. So the quadruple therapy seems to be a new standard of care. This was based on the data from 2 important trials, the Griffin trial, which added daratumumab to triple combination VRD, and Caspia trial, which added dara to the VTD arm. And this is the schema of the Griffin trial, which was presented at the ASH recently, and comparing DVRD with VRD, followed by either DR maintenance or Revlimid maintenance. And it did show significantly improved or deeper responses, both stringent CR as well as CR, as compared to the VRD arm. And although the PFS and the overall survival does not seem to be different as the follow-up is very short, but the response rates are very high, and it is expected that the PFS and overall survival will be better in the DVRD arm. The other question that remains is the, what is the role of autograph in 2021? And this is the updated results from the IFM 2009 trial, which compared RVD to autologous transplant following RVD. And at an 8 years follow-up, it still shows that the transplant arm is doing much better in terms of PFS as compared to the RVD, with a 30% reduction in the risk of progression in the transplant arm. So, and at 8 years of follow-up in the transplant arm, actually 1/3 of the patients actually have not relapsed, which suggested that the transplant might be giving a long-term remission, as well as a proportion of patients might be cured. This has also been shown in the recent FORD trial, which used carfilzomib instead of bortezomib, and compared with there were 3 arms with KCD, KRD, and KRD alone. The first 2 arms were, followed by stem cell transplant, and and there was a randomization at the between Revlimid and carfilzomib Revlimid, and this also showed that there was a PFS advantage in favor of the transplant arm, as well as there was an improved PFS too in patients who had a combination of carfilzomib Revlimid as a maintenance treatment. So therefore, the transplant remains as standard of care even in 2021. Now, we also know that the maintenance has also become a standard of care, especially in patients who are treated with autologous stem cell transplant. This is the slide from Myeloma 11 trial, which was one of the largest clinical trials ever conducted in myeloma. And at the end of induction treatment, autologous transplant patients were randomized to have maintenance treatment with lenalidomide or observation, and there's certainly both a PFS as well as an overall survival benefit in younger fetal patients. And the meta-analysis of all the trials which have used lenalidomide maintenance after autologous transplant clearly shows that there's a benefit of giving len maintenance post autologous transplant, as well as there is overall survival benefit. And this is shown also in transplant non-eligible patients. However, the overall survival has not been shown in the elderly patients as yet. So what are the frontline treatments for non-transplant patients or transplant non-eligible patients? So till now, we've been using either a combination of Velcade, melphalan, prednisolone, or Revlimid Dex, or even a lighter form of VRD and or VCD and MPT. So that's depends on whether we are working in the US or Europe, and depends on the funding. And the VMP over MP was tested in the VISTA trial, which clearly showed a advantage of PFS in favor of VMP, whereas the Revlimid Dex was shown to be superior to MPT and a short form of Lendex, that's 18 cycles. So the continuous RD was shown to be superior to these two arms in the first trial, and hence this is the standard of care for non-transplant or elderly patients. And the SWOG trial also obviously showed VRD was better than RD, but this was associated with a bit of toxicity in the elderly patients. So the current algorithm for upfront treatment in elderly myeloma patients is, you can give either a lighter form of VRD, but if VRD is not funded, then a combination of Revlimid dexamethasone or VCD or PD or VMP is the standard of treatment care at the moment, followed by lenalidomide maintenance. But again, with the introduction of monoclonal antibodies like daratumumab, a number of trials have shown that the combination of the daratumumab with the Velcade or Revlimid-based treatments actually improves the depth of response and may eventually improve the survival. So this has been shown in the MAIA and Acyclone trial. There's also evidence that combining ixazomib with Lendex also improves the PFS in elderly myelomas. So this is the schema of MAIA trial, which compares Dara Lendex with lenalidomide and dexamethasone in elderly patients, and clearly shows at 48 months that there was a significant PFS advantage in favor of daratumumab containing arm. And this was shown in that the benefit was for all the high-risk patients, including ISS stage 3, as well as those with high-risk cytogenetics. And the response were deeper. Both CR and stringent CR were much higher in the daratumumab containing arm as compared to RD, and which was maintained at 12 months. The MRD negativity was significantly different in DRD arm compared to RD. Although there have been safety issues with more infections in the daratumumab arm, especially pneumonias and viral infections, particularly herpes zoster, but the trial did not, however, show that the discontinuation rate was not higher in the triple regimen as compared to RD. However, it will be interesting to see what happens in real life. Now, let's go to talk about the current treatments for the relapsed myeloma. This is one of my patients who you can see has had multiple treatments, and it basically shows that multiple myeloma patients eventually relapse, and with each treatment, the duration of response is usually short-lived. So currently we have we're fortunate to have a number of agents available because there is data which is matured from a number of trials which have used combination treatments, which includes the daratumumab containing regimens like KRD, DVD, DRD. There are also some carfilzomib-based treatments and Ixel and Dex. So when we are thinking of treating a relapsed myeloma, it will all depend upon what the patient has had at the upfront and how they fared with it. Have they developed, what side effects they had, what are their comorbidities, and what are the expectations of the physician and the patient when we're treating the relapse. Therefore, we can choose. And at first relapse, the current recommendation is again a triplet regimen. Whereas when we are down the line, then there are a number of obviously new agents like anti-BCMA agents in clinical trials at the moment, which show quite promise, and also a number of novel agents, which we'll talk about a little bit later, are also in the clinical trials. So if you have a patient who has had first relapse after bortezomib-based regimen, so they may or may not have had lenalidomide, but as long as they're not refractory to len, then the current recommendation is that we should consider triplet regimen where RD is a backbone. So this is the a comparison of a number of triplet regimens and at first relapse in patients who had bortezomib as an induction. And it shows that there's quite impressive overall response in all these triplet regimens, but perhaps the best results seem to be in the dara-containing regimen with the deeper CRs. So this is the the results from the Pollux trial, which compares dara-RD with RD and shows an impressive progression-free survival of 44 months versus 17 months. In favor of the dara arm, and if we look at the patients who have had lenalidomide-based treatment, for example, patients who have had Lendex continuously or followed by len maintenance, they are considered to be lenalidomide refractory. So for those patients, we will the recommendations that we use Velcade-based treatment in triplet combinations, and this is the a comparison of various trials here where Velcade is in the backbone. And again, we are seeing a significant overall responses between 70 to 80%. And the again, dara-containing regimens seem to be giving the deeper responses. So this is the results of the Castor trial, which compares dara VD versus VD. And again, there's a PFS advantage in favor of daratumumab containing regimen. So what do we do with patients who are IMiD or proteasome refractory? In other words, we call, and also they may be monoclonal antibody refractory, what calls triple refractory disease or penta refractory disease. The prognosis of these patients is extremely grim, and majority of these patients will die within 6 to 12 months. Now, we have a number of agents which are targeting this antigen called BCMA. Now, BCMA is an antigen which is expressed on majority of the plasma cells. It's not expressed in any other tissue, and it promotes cell growth, myeloma cell growth, and chemotherapy resistance. And the expression of BCMA is associated with poor outcome. There are a number of anti-BCMA agents in clinical trials at the moment. I've listed here some of the antibody drug conjugate. The FDA has approved the belantamab mafodotin recently. There are also bispecific T-cell engagers, which especially AMG 420701, and of course a number of CAR T-cells. The belantamab mafodotin is an antibody drug conjugate, which is a humanized IgG1 antibody, and it is conjugated to this agent called MMAF, which is it's like brentuximab you have, but except that this drug does not cause any neuropathy, but it has a peculiar side effect of it can cause keratopathy. Now, this combination has it leads to either direct cell death or data that supported the FDA approval for belantamab was on the basis of DREAM2 study, which evaluated 2 different doses of the drug, and this was a triple class refractory patients, and the response rates were around 30%, with a duration of response about 11 months, which is not which is very good for triple class refractory myeloma patients. And this is now being studied in combination with Velcade-X in DREAM6 study with the different doses. And the response rate seems to be very impressive, around 78%. Although in DREAM6, there are also patients who have had only 1 relapse. Obviously, the follow-up is very short at the moment. And as I mentioned earlier on, the most important side effect we see with the belamaf is the keratopathy, and nearly 100% of the people will get keratopathy. Although it seems to be resolvable once there is either an interruption or delay in the dosage, and the majority of the patients do recover. There's also the CAR Ts have now been FDA has approved a first CAR T cell therapy for myeloma, the ide-cel, and there are others in development. So this is a list of all the different CARs which are being used in myeloma at the moment, and at different stages of development, and most of them are showing very impressive response rates in previously treated, multiply treated myeloma patients, with the average of 6 to 8 lines of treatment, and the response rates seem to be around 70 to 80%. And as you can see, majority of the patients are developing the CRS or the cytokine release syndrome, which although is resolvable with steroids and the other drugs, but nevertheless is a very important side effect. And again, a proportion of patients develop neurotoxicity. Interestingly, the allo CAR Ts are also on the horizon now, and there are trials going on. The advantage obviously would be that the allo CAR Ts would be available off the shelf, and these can be transplanted within 5 days of the enrollment, whereas the conventional CAR T takes at least a few months. So this is the trial, the KARMA trial, which on the basis of which FDA approved ide-cel for relapsed myeloma patients, and as you can see, at different doses, the response rates in this difficult class of patients who have been multiply treated in the past, and have been some of them have been with high risk cytogenetics, and some of them having extramedullary disease, and the response rates are around 70 to 80%, with about a third of patients getting a CR. That's very impressive, although the duration of response is short at the moment. Obviously, more follow-up is needed. And as I mentioned, majority of the patients will get CRs, and a proportion will also get grade 1 to 2 neurotoxicity. The cilta-cel is another CAR construct with which actually targets 2 BCMA epitopes, VH1 and VH2, and seems to be giving much better responses, as you can see here in this short group of patients, about response rate of 88%, around 60% patients getting into complete remission, which is obviously remarkable. So the data is obviously maturing, and we in United Kingdom are not, it's still not a standard of care, and there are only few centers which are set for CAR-T, but obviously this is slowly growing up. A word about the bispecific or T-cell engagers or bispecific antibodies. That's the example here, which basically these antibodies, they target both BCMA as well as T cells. So in other words, they bring the T cell closer to the myeloma cell, exactly like CAR-T, except that these are obviously available off the shelf and can be used in not too specialized centers. And this is a summary of a number of bispecs which are currently under evaluation. And again, we're seeing quite impressive responses. But again, even with the bispecs, we're seeing significant number of patients getting CRS and proportion also getting neurotoxicity. And there are these three agents which the data was presented in the ASH. These are very novel, and the clinical trials are currently going on. One is the new IMiD, the iberdomide, which seems to be more potent than the conventional len or pomalidomide in terms of just binding to cereblon, and with its potential target on the target proteins. And there are trials going on in combination with daratumumab and steroids. And the other agent called selinexor, which is an XPO inhibitor. What XPO does, it transports or exports the tumor suppressive protein out of the nucleus, and the XPO inhibitor selinexor prevents that happening and then promotes the cell death. Again, on its own, it doesn't seem to have a significant response, but there are a number of ongoing trials in combination with either carfilzomib or pomalidomide and daratumumab. As you can see, this is a penta-refractory group of patients, which is a very difficult group of patients with poor prognosis, obviously, and we are seeing response rates around 50 to 80% in different trials, and a proportion of them getting CR, which is quite significant for this group of patients. And so to conclude, we are seeing that there is both a PFS and overall survival has markedly improved in recent years in myeloma patients, and many patients now live longer. The frontline treatments of myeloma seem to be now changing, and there's a trend towards using quadruple therapy than the triplets, although it will obviously need funding, and the funding bodies in different countries obviously will have different take on this. Although we're seeing deeper responses with the quadruple therapy, but this obviously has to be weighed against the potential toxicity. Again, at first relapse, the triplets are preferred, and there are a number of BCMA targeted therapies now available, and they seem to be promising. And even the newer agents are also on the horizon and showing a promise in penta-refractory myeloma patients. However, what will be interesting to see how we sequence these agents, and whether these can be used in the early lines of therapy, particularly the CAR-T and the others, whether they can be as a substitute or as an alternative to autologous stem cell transplant. So there are certain trials underway. And lastly, should we be actually making decisions on the basis of MRD, so that some patients can be spared the toxicity of continuous treatment, whereas others who remain MRD positive, whether they can be targeted with more intense treatments. I think I'll stop there. Thank you very much for your attention.
Thank you, Dr. Wanro, for a very elaborative talk on myeloma and update. So now we're going to move on to our next speaker, Dr. Amjad Hayat. He's a consultant hematologist at Galway University Hospital in Ireland. He's director of stem cell lab and transfusion service, lead in phase 1 hematology trials at Galway University Hospital, Republic of Ireland. He's going to be talking about diffuse large B-cell lymphoma, current practice, and the future. And we'll move on to Dr. Amjad Hayat for his talk. Thank you.
Hello there. My name is Dr. Amjad Hayat, and I'm a hematologist at University Hospital Galway, Republic of Ireland. I'm also the director of the stem cell lab and transfusion services for the region. It is my pleasure to be talking to you today about the current management of diffuse large B-cell lymphoma and what the future might hold. I wish I had been there, but hopefully next year. I have nothing to disclose for this talk. So what are the challenges that we face in treating our patients in 2021 with diffuse large B-cell lymphoma? Is it our failure to predict patients who would fail first-line treatment, which remains DLBCL? Or is it our choice of first-line treatment that we are unhappy about, taking into account disease characteristics such as molecular subtypes and cell of origin or fitness? Or we are more concerned whether we should use CNS prophylaxis or not? Maybe we are happy with our first-line management, but are more concerned when the patient relapses with a poor outcome, as we know. Or maybe we are worried about that we can't access any of the newer treatments. We may also think about how to improve our first-line management of DLBCL. So as we are talking about the treatment of DLBCL, this audience knows very well that the treatment over the last 2 to 3 decades has remained R-CHOP. And it is a good treatment as it cures 60 to 70% of patients, but it's not perfect. Because if you can see here in this curve, within the first 2 years, 30 to 40% of the patients either have primary refractory disease or have relapsed. I think we need to concentrate on improving the outcome of these patients, but also taking into account that whatever treatment we adapt, we should not detrimentally affect the outcome of the patients that we are already curing. So how have we attempted over the years to overcome this resistance? And the principle in general that has been followed is known as R-CHOP plus X. So either you dose intensify the chemotherapy part or add an additional drug. In the pre-rituximab era, there were a number of dose intense chemotherapy regimens, and I've just mentioned 2 of them, but with no particular improvement. In the rituximab era, the same principle has been followed, and this is one such regimen from the French group, RACVBP, which did show some improvement in the event-free survival and overall survival, but only for under 60 and with age-adjusted IPI of 1, at the same time being massively toxic and difficult to deliver. The Germans attempted by bringing in the principle of dose density by giving R-CHOP every 2 weeks in the Recover 60 trial. Unfortunately, no improvement. They also attempted to optimize rituximab, and you can see that a number of acronyms were used. The first one was denser R, which gave more retux within the time scale of R-CHOP treatment. Then was the smarter R-CHOP, where more retux was given over a period of year. And eventually sexier R-CHOP, where the dose was increased from 375 to 500, but with no real improvement. Given the success of follicular lymphoma and rituximab maintenance, this was attempted in DLBCL as well, but again, no improvement. With the advent of newer anti-CD20 monoclonal antibodies such as ofatumumab and venetoclax, this was attempted in the large Goya trial of venetoclax CHOP was compared to R-CHOP, again, no improvement. Past meta-analysis would have suggested that dose-intense treatments such as R-Codox-M, IVAC, or hyper-CBAD, or dose-just DPOC may be of benefit. Unfortunately, despite great expectations, in the large Alliance CLGB 50303 trial with 524 patients, dose-adjusted DPOC was no better than R-CHOP. High-dose chemotherapy and autologous stem cell transplant in the upfront setting has been attempted a number of times. The SWOG 9704 trial and the Italian DLCL04 trial did show an improvement in PFS, but no improvement in overall survival. In another Italian trial and the German trial where our mega-CHOEP was used with 3 sequential autologous stem cell transplant was just plainly too toxic. We also know that diffuse large B-cell lymphoma is heterogeneous with GCB and ABC subtypes as known through gene expression profiles. ABC type being the one with the worst outcome, secondary to NF-kappa-B activation. In order to modulate this NF-kappa-B activation, bortezomib was added in 2 trials, the Pyramid and Remodel trials, and compared to standard R-CHOP, unfortunately no improvement. Robust trial with over 800 patients compared R-CHOP to lenalidomide plus R-CHOP with no improvement. And in the large Phoenix trial, ibrutinib was added, and in actual fact, it was more toxic in the elderly. So as the current guidelines for DLBCL stand, both the ESMO and the NCCN, the first recommendation is to use R-CHOP. One could select for higher risk patients RACVBP as per the ESMO guidelines and dose-adjusted EPOC as per the NCCN guidelines. I do think that there has been a change in the treatment of localized limited DLBCL. This is defined as stage 1, 2, accounts for 30% of DLBCL, predominantly GCB, more males in extranodal disease. We do need to remember when we are comparing trials from before 2000 or before the advent of PET, that some of those patients who were staged in the older trials as stage 1, 2 disease could be upstaged nowadays. Similarly, the definition of bulk has been variable across trials, some using 5 centimeters, some 7.5, and some 10 centimeters. It is also important to remember that extranodal sites such as testes and primary metastatic B-cell lymphoma are not included. In the landmark trial published by Miller et al. In 1998, localized limited stage DLBCL was randomized to CHOP 3 times plus 45 grays of radiation versus CHOP 8 times. Remember, there was no rituximab at the time. This trial did show a PFS advantage to the dose attenuated CHOP plus radiation. I guess the most important message that came across from this trial was that patients who did not have or had one of these risk factors demonstrated here on the screen, including elevated LDH or age over 60 or stage 2 disease, had a better outcome as compared to patients with 2 or 3 risk factors. SWOG subsequently added rituximab to the same regimen, which was CHOP 3 times plus radiation, with an improvement in progression-free survival. Again, there was an important message hidden here. And you can see that there were continued event-free survival events, probably pointing to a unique disease biology despite early stage disease. So as we move into the current decade, patients without risk factors have favorable outcomes, as we have demonstrated. The question has to be asked, can we decrease therapy? Similarly, patients with risk factors need alternative approaches and certainly long-term follow-up given the risk for continued relapse. And I think that brings us to the 2 approaches. One is the PET-adapted approach and one is the omission of radiation. So in the FLIER trial, 6 cycles of R-CHOP were compared to 4 cycles of R-CHOP with no radiation therapy in young patients with no risk factors, no disease bulk, an IPI of 0. After a median follow-up of 66 months, here you can see in the top graph that there was no difference in the outcome between the 2 arms. And in the bottom graph, you can see that the risk of relapse was no different either. Based on this trial, NCCN guidelines now recommend that R-CHOP 4 times is a treatment choice. Another trial that has demonstrated non-inferiority of the attenuated treatment was presented at this last ICML by Bologna and colleagues from the French LISA group in LNH091B trial, which is an early PET-adapted trial. They compared 6 cycles of R-CHOP to 4 cycles of R-CHOP if the PET after cycle 2 was negative. 650 patients with stage 1-2 disease, 18 to 80-year-old with age-adjusted IPI of 0. Bulk was allowed in this trial and was defined as more than 10 centimeters. So after a 5 years follow-up, the PFS at 3 years is not inferior between the two arms. In my opinion, these two trials demonstrate that in early stage DLBCL, especially if we use PET to guide if the patient is PET negative after 2 cycles, we can dose attenuate the treatment to 4 cycles and avoid radiation. So moving on to the relapsed refractory setting, this is the multi-cohort international retrospective SCHOLAR-1 study, which followed patients after the initiation of salvage treatment. The patient group included was primary refractory, refractory to secondary line, or relapse with an early relapse patient. And here you can see an absolutely abysmal outcome with a median overall survival of 6.3 months with a CR rate of 7%, and especially for those patients who could not undergo autologous stem cell transplant. So what are the options for relapsed refractory DLBCL? I think the most important thing always to consider as a physician is what exactly is the goal of treatment. In my view, and especially given that the newer treatments that are coming, that are upcoming, such as CAR-T, which do not cure every patient, autologous stem cell transplant in patients who have chemosensitive disease to any of these second-line treatments should be considered for an autologous stem cell transplant. Allogeneic stem cell transplant is rarely an option, but may be considered in an odd patient. For those patients who are transplant ineligible, up until now, palliative single agent or multi-agent chemotherapy would have been considered, or palliative radiation. This dogma is being changed with the advent of CAR-T and novel agents. So the 3 CD19-directed CAR-T products that are in clinical development and have been approved by FDA for DLBCL in second, third line treatment are Axi-cel, Tisa-cel, and Liso-cel. The 3 pivotal studies that led to the approval of these products, ZUMA-1, Juliet, and Transcend, show that Axi-cel and lisocabtagene may have better response rate, but the overall survival at 12 months was not really different. The toxicities are lower for Tisa-cel and Liso-cel products. Longer-term follow-up has demonstrated that we can achieve long-term remission rates in these patients between 34 and 40%. It also demonstrates that not all patients are either a select choice for the treatment because of its toxicities, or that they are cured by these treatments. Well, I'm not going to dwell on this cartoon for too long. You can see that there are a number of potential druggable targets that are currently being looked at. On the left-hand side of the slide, you can look at the bispecific T-cell engager, and then moving on to the right, naked antibodies or antibody drug conjugates or antibody radionuclide conjugates are being looked at. So the first drug that was approved for relapsed refractory DLBCL is polatuzumab vedotin, which is an anti-CD79B antibody drug conjugate, CD79 being universally expressed on B cells. MMA, once the antibodies internalize, the MMAE toxin is released, which causes microtubule cross-linking and apoptosis. In the GO29365 phase 1/2b trial, which led to the approval by FDA of Pola-BR, it had a safety run-in of Pola-BR only, followed by a randomization of Pola-BR versus BR, and then an extension phase. This is a finite treatment for 6 cycles. And here you can see on the left in red that Pola-BR had a better overall response rate and a complete remission rate. But more importantly, this translated into a benefit in overall survival. The objective responses were across disease categories. It did not depend which line of therapy, second or third, whether the patient was refractory to the last treatment or not, or whether they were primary refractory or not. Further follow-up revealed a continued PFS and OS advantage, and you can see at the bottom that the 2-year PFS is 28.4%, and the 2-year overall survival was 38.2%, and there seems to be a tail in the curve. The second drug approved is selinexor. It's an XPO1 inhibitor that stops the migration of tumor suppressors from inside of the nucleus, thus leading to apoptosis. It is an oral drug and is given as 60 milligrams twice weekly. And in this phase 2 open label study, it was given to patients with relapsed refractory DLBCL who were not eligible for an autologous stem cell transplant and had a prior 2 to 5 treatments. Here you can see the response in 127 patients, which is modest. Overall response rate was 28.3% with a CR of 10.2 and a median duration of response of 9.3 months. I think it is important to point out that patients who got complete remission did get a longer remission. It does have unique toxicities. It causes fatigue, diarrhea, and can cause significant weight loss. And in my opinion, the drug should be given once a week rather than twice a week. The next drug that was approved is tafasitamab. It is a naked anti-CD19 monoclonal antibody that is Fc engineered with increased antibody-dependent cell-mediated cytotoxicity and cellular phagocytosis and direct cell death. It was combined with lenalidomide, which again is an immunomodulated drug, and the hope was that the two would be synergistic. So in the phase 2 L-MIND study, relapsed refractory DLBCL patients with 1 to 3 prior regimens were initially selected. Primary refractory patients were not included till an amendment came through, but eventually when the study was presented, there were only about 15% primary refractory patients. It is an IV drug given initially weekly for the first 3 cycles, then once every 2 weeks from cycle 4 to 12 and onwards until disease progression. Lenalidomide is given as standard 25 milligrams per day, PO, days 1 to 21, but only for the first year. In the published paper, 80 patients were included for the efficacy data, and you can see the impressive results with an overall response rate of 60% and a CR rate of 43%. The drug was actually quite tolerable, and most of the side effects were related to lenalidomide. The last drug that has been approved is loncastuximab tesirine, which I'll call Lonca from here onwards. It is an anti-CD19 monoclonal, humanized monoclonal antibody that is conjugated to a potent PBD, pyrrolobenzodiazepine dimer, which causes DNA cross-linking. So in this phase 2 LOTUS-2 trial, which was an open label study, patients relapsed refractory DLBCL with more than 2 lines were given the treatment, Lonca, 3 weekly IV for the first year, and thereafter once every 3 months for 3 years or till disease progression. 145 patients were included, 87 were DLBCL with a median 3 prior lines of treatment, 20% were primary refractory, and 58% were refractory to their last treatment. And here you can see the overall response rate was 48.3% with a complete remission rate of 24%. I think it is important to mention that most patients who do respond early in the disease after 2 cycles, which may preclude giving it over longer term, but I think it is beneficial. The PFS and OS demonstrated here that the median PFS was 5.9 months with an OS of 9.53 months, with a slight tail in the curve. It is a well-tolerated drug with the majority of treatment emergent adverse events being hematological and elevation of gamma GT. In my opinion, I think one of the most exciting group of drugs that is being looked at the moment are bispecific T-cell engagers. So these recognize 2 epitopes, one on the B cell, which is CD19 or 20, and one on the T cells, which is CD3, thus bringing autologous T cells in close proximity to the tumor cell. So on the left, you can see that the first drug that was approved is blinatumomab, and it's approved for use in ALL, had modest activity in DLBCL. Of the drugs that are currently being looked at, you can see that the one in the middle, glofitamab, and one on the right, epcoritamab, have significant activity in DLBCL with complete remissions in over 50% of the patients. The side effect profile is not very dissimilar to CAR-Ts with CRS and ICANS, but at a lower frequency and severity. Polatuzumab has also been tested in an upfront setting in the POLARIX study. Polatuzumab plus R-CHOP minus vincristine is tested here against R-CHOP as standard. This is a media press release from the company claiming that in the first 20 years, something is about to dethrone R-CHOP from a standard of care. The data will be presented at ASH, and I'm eagerly awaiting to see the results. So in summary, R-CHOP remains the standard as of today. We could use intensified regimen in some cases. I did not touch upon the CNS prophylaxis. Despite the controversy, I still use it as high-dose methotrexate combined with R-CHOP in patients with high CNS IPI. I do think using PET guidance and treatment attenuation has changed our approach to the management of stage 1-2 disease. In the very near future, I'm hoping that novel combinations such as polatuzumab CHOP plus tafasitamab lenalidomide CHOP is going to change our management in the upfront setting. Similarly, in the relapsed refractory setting, with the advent of CAR-Ts and novel agents, currently this is being looked at in comparison to autologous stem cell transplant. I do think we can use PET more intelligently by looking at other PET modalities such as total metabolic tumor volume to have a better positive and negative predictive value. And also, I think in the near future, we'll be using MRD through circulating tumor DNA to better predict early relapse and management at that stage. I thank you for your attention.
Thank you, Dr. Amjad. Again, a very comprehensive talk from Dr. Amjad Hayat about diffuse large B-cell lymphoma. And now we're going to move on to our next and last talk of the session by Dr. Sridhar Chaganty. He's a consultant hematologist at University Hospitals Birmingham NHS Foundation Trust, and he's a clinical service lead for clinical hematology. He has completed his PhD in cancer studies from University of Birmingham, and his special interests are in lymphoma and stem cell transplantation. He's leading the CAR T-cell therapy program at Queen Elizabeth Hospital, Birmingham, and he's going to talk about overview of CAR T-cell therapy in diffuse large B-cell lymphoma. So over to Dr. Sridhar Chaganty.
Good afternoon, everyone. Thank you for inviting me to your symposium and asking me to talk on CAR T therapy for diffuse large B-cell lymphoma. I'm Sridhar Chaganty. I work at University Hospital Birmingham, and today I'll be talking to you about the current approved indications for CAR T therapy in diffuse large B-cell lymphoma. I'll show you outcomes in clinical trials and in the real world. So the term large B-cell lymphomas encompasses diffuse large B-cell lymphoma and its various histologic entities, high-grade BNHL, including double and triple hit lymphoma, primary mediastinal B-cell lymphoma, transformed follicular lymphoma, and in some cases, grade 3B follicular lymphoma. So these are the currently approved CAR T products for diffuse large B-cell lymphoma. The first two are approved in Europe and in US. The third one is currently approved in the US, and as the date of this recording in August, it is not yet approved in Europe and UK, but we expect it to be approved soon. So all three products are approved for the high-grade B-cell lymphomas, or large B-cell lymphomas, as we call them. for patients who have failed 2 or more lines of therapy. So oxycaptogene cilolacicel is approved for DLBL, high-grade BNHL, transformed follicular lymphoma, and primary mediastinal B-cell lymphoma. Tisagenlecleucel or Tisacel is approved for DLBL, high-grade BNHL, and transformed follicular lymphoma. Lisocabtagene maraleucel or Lisacel is currently approved in the US, as I've said, and it's approved for all the large B-cell lymphoma indications. So CAR T therapy has really come into the picture because we know that outcomes for patients with diffuse large B-cell lymphoma who have failed 2 or more lines of therapy are very poor. Many of you will be familiar with the data from SCHOLAR-1 study. This was pooled analysis of over 600 patients from a couple of clinical trials and large databases in US and in Canada. And this was looking at patients who had failed 2 or more lines of therapy, or who had primary refractory, or who relapsed early after an autologous stem cell transplant. With subsequent chemotherapy, the outcomes for these patients are extremely poor. Objective response rate of only 26%, and there is CR rates of only 7%. And as you can see, only 10 to 15% of patients achieve long-term survival. So this was the data in the pre-CAR T era. And shown here is data with Yescarta or Axi-cel. This is data from the pivotal ZUMA-1 study, which led to approval of Yescarta for this group of patients. As you can see, the overall response rates are an impressive 74% with CR rates of 54%. So very different to what we saw on the last slide in the pre-CAR T era. And on the right side of the panel, you can see survival for these patients. This is overall survival as updated at ASH last year. With a 4-year follow-up now, 44% of patients are alive. So that's very different to what we saw on the last slide. This is impressive results compared to what was achievable in the pre-CAR T era for these patients. This is data with Tisagenlecleucel or Tisacel. This is the pivotal trial Juliet, which led to approval of Tisacel for the same indication. And again, as you can see, the overall response rates are quite impressive, 53% with CR rate of close to 40%, and a 3-year survival of 36% for these patients. So slightly less than Axi-cel, but nonetheless very impressive compared to what was achievable prior to CAR T therapy. And you must remember that this is not direct head-to-head comparison. These are different sets of patients. We've also seen outcome in the real world. This is data from 17 centers, 275 patients. This is US real world data. And the striking thing is the overall survival is very comparable to what was reported in the ZUMA-1 study. Important to note that a substantial number of patients, about 43% of patients included in this analysis, would not have met the eligibility criteria for the ZUMA-1 study, as in they had a worse performance status or they did not have good enough organ function. But nonetheless, their outcome is very similar to what was reported in the ZUMA-1 study. This is data from UK. Some of you will know that in the UK we have a national panel which approves CAR T therapy for patients. And this is data from EHA last year. 276 patients were submitted for approval to the national panel. Just over 250 patients were approved. So a majority of patients considered by the panel are approved for the treatment. But as you can see, a large number of patients do complete apheresis, but the total number of patients receiving the infusion was 183. So between 250 plus patients approved and 180 patients receiving the infusion, there is about a 25% dropout rate. A lot of this dropout is because of progressive disease, whilst patients are waiting for the cells to be manufactured and infused. In the UK, the average time runs around 7 to 8 weeks from the time of approval to infusion. So of the 183 patients who received the infusion, we have a 3-month response evaluation on 156 patients, and 114 patients were evaluable for the 6-month time point evaluation. And this is toxicity data on the patients. 133 patients received Axicell and 50 patients received Tisacel. I think it's fair to say that Axicell produces more immediate toxicity, both in terms of CRS and neurotoxicity, as you will see on this slide. But the striking thing we find is the toxicity for both the products was less than what was reported in the comparative trials for these products. So when we compare the toxicity we see with the Zuma 1 and Juliet studies, we find that we are seeing less grade 3 CRS and also less grade 3 neurotoxicity. We do have greater use of tocilizumab and steroids compared to what was used in the pivotal trials. Our ICU admission rate varies between the two products, roughly between 20 to 35%, and a small number of patients will have prolonged cytopenias following CAR T therapy. And this is outcome data on the patients with Yescarta or Axicell. 112 patients who have received the infusion, best overall response rate of 76% with a CR rate of 43%. So that is very comparable to the Zuma 1 study. But when we look at the 3-month response, the response at 3-month time point, it's an overall response of 45% with 30% CR. And as you can see, the main problem is close to around 50% of patients who receive the infusion will progress by the 3-month time point. However, for the 30% of patients who were in a CR at 3-month time point, we had 22 patients were evaluable for the 6-month response, and the majority will retain the response. So again, if you achieve a CR at 3-month time point, you're quite likely to maintain that CR. But if you have a PR at the 3-month time point, we only had 10 patients who were evaluable for the 6-month time point. And as you can see, it's a mixed bag really. Some patients have progressed, some patients will continue with a PR, and some patients will convert to a CR. And this is survival data on our population. I will show you some updated survival data in subsequent slides, but this was as of EHA last year for the 183 infused patients. So 253 approved, 183 infused. As you see, the top gray line is patients who received the infusion, and for them the median overall survival is just over 13 months. The broken gray line is patients who did not receive the infusion and they have a very poor outcome, and the black line is intent to treat analysis. And the median overall survival on the ITT population is 8.1 months. This is EFS data, rather underwhelming. Median EFS is only 3.2 months and a 6-month EFS of just under 40%. So in the next few slides, we will examine the factors that might predict for outcomes of CAR T therapy. This is all data coming from the real world now. So we'll be looking at age, looking to see if outcomes are comparable in the elderly and younger patients. And we'll also look at transplant fit patients versus patients who are considered to be unfit for transplant. And then we will look at disease characteristics, disease burden, tumor volume, high LDH, external sites, and patients who have rapidly progressive disease to see if these influence outcome of CAR T therapy. So first, age, using 65 as a cutoff, which is pretty standard in many centers for considering a patient as transplant eligible for high-dose chemotherapy and autologous stem cell transplant, I mean. So this is data from CIBMTR, 330 plus patients under the age of 65 and close to 200 patients over the age of 65. So this is quite a large data set. And if you look at the age range for patients over the age of 65, goes from 65 to 86. So that's quite impressive. Median age is 70, so a bulk of patients would be between 65 to 75 in this group. And if you look at their outcomes, for PFS and OS, there is no difference for patients over the age of 65 and under the age of 65. If anything, patients over the age of 65 seem to be doing slightly better, and that may be a reflection of the fact that you may be paying more attention to selecting out fitter patients to receive this treatment compared to the younger population. This is UK data updated at EHA this year. This is data on 402 patients, and we analyzed this data by patients' fitness for transplant as defined by the CAR-T center. So we had of the 402 patients who were approved by the national panel by this time point, 81 were deemed to be unfit for stem cell transplant by the CAR-T center. A major cause of considering a patient unfit would have been age greater than 70 in many cases, but there were patients with inadequate organ function or performance status that influenced the decision as well for transplant fitness. 298 patients received infusion in the end. 245 of these were deemed to be transplant fit and 53 were deemed to be transplant unfit. And as you can see, both for EFS and for overall survival, there was no difference in outcome for transplant fit and unfit patients. 12-month EFS running at 36% and 12-month OS just under 50%. What we did notice is the dropout rate from approval to infusion was around 24% for the transplant fit patients, but was slightly higher for the transplant unfit patients at 35%. So maybe if you're transplant unfit, you have a greater chance of dropping out and not receiving the infusion. But if you do receive the infusion, then your outcomes are identical to the transplant fit patients. So what about tumor volume? So this is data using PET and metabolic tumor volume. This is retrospective data from the US. And as you can see, patients who have low metabolic tumor volume as defined as less than median of this group did much better than patients who had a high metabolic tumor volume. There was a big difference in the median tumor volume for the low and the high groups. But the difference in both OS and PFS is quite remarkable. And a lot of this difference seems to be because of rapid early progression, as seen on the PFS curve. And this is comparing outcomes by LDH at the time of conditioning. And this is again real world data coming from US multi-center series, data on something like 250 plus patients. And as you can see on the red lines, patients who have elevated LDH at the time of conditioning have a high risk of rapid early progression and have much worse PFS and OS compared to patients who have a normal LDH going into CAR-T therapy. So this is data coming from the French group. This was presented in EHA. This is data on over 600 patients approved by French CAR-T panels. And they are looking at what happens with bridging. So on these two survival curves, the left panel is showing PFS and the right one is showing the OS. The blue line is patients who did not require any bridging therapy. And the red lines are patients who achieved a CR or a PR or at least maintained a stable disease through bridging therapy. The black line is patients who had progressive disease through bridging therapy. As you can see, patients who have progression through bridging do extremely badly. And again, they seem to progress soon after CAR-T therapy. And their median PFS is again just over a few months, really. This is multivariate analysis on our UK patients. This was data from EHA last year. And I would ask you to just concentrate on the last column, which is looking at the overall survival. And if you look at the p-values, which are significant here, patients who have multiple external sites seem to have much worse survival. Patients who have a ECOG performance status of 2 at the time of infusion seem to have much worse outcomes compared to those who have 0 or 1. Patients who are rapidly progressive disease seem to have much worse outcomes, and patients with elevated LDH have much worse outcomes. So this is very much on lines of what we have seen from other large groups who have reported real-world data. So, in summary, I think it's reasonable to say that CAR T-cell therapy presents a major advance for patients with diffuse large B-cell lymphoma who have relapsed after 2 or more lines of therapy. The best overall response rates with the current approved products are running around 60 to 80%. I would say the best CR rate are around 40 to 60%. The median overall survival for infused patients is around 12 months and median PFS around 3 to 6 months. The overall survival at 2-year time point is between 40 to 50% and PFS around 30 to 35%. And I think it's probably fair to say that we expect that majority of these patients are cured if they have remained in ongoing continuing remission for 2 years or beyond. But as we have seen in the data, there are several limitations of current CAR T products. The time that takes from approval to infusion is around 7 to 8 weeks, and around 20 to 25% of patients who have been approved for treatment fail to receive the infusion, largely because of progressive disease and declining clinical status in the interim. And as we have seen, outcomes are much worse for patients who have a high tumor burden disease or a high LDH, rapidly progressive disease. So clearly there is a long way to go to improve outcomes for these patients, and there are attempts being made to improve outcomes of CAR T therapy. A major problem with CAR T therapy currently is relapse, and we know that roughly half of the patients who relapse will relapse with a CD19 negative relapse. So one approach that is being looked at is to use dual targeting CARs that target CD19 and CD20 or CD19 and CD22 to try and see if we can reduce the risk of CD19 negative relapse. The other approach which is also being looked at is to see if we can enhance the activity of the CAR T cells themselves by combining CAR T therapy with immune checkpoint inhibition. So Alexander is a trial that is running in the UK currently with autologous CAR T product, which is called Auto3. It is a dual targeting CAR, and it is being used in combination with pembrolizumab. We have seen some promising initial data, but we really need to wait to see more mature data with these products. There's also attempts being made to use off-the-shelf CARs to get rid of this long waiting time that you have between approval and infusion, during which patients will deteriorate and ultimately not receive the product. So there are attempts to use third-party derived allogeneic CAR T cells, and we've also seen some early data, very promising data on using allogeneic CAR NK products. And these are, whilst I would say these are exciting times, it's probably too premature for us to say that these products are going to be any better than the current approved products. So we really need to wait to see more mature data on this. And we're also seeing attempts being made to bring forward CAR T therapy from third line and beyond to second line or even first line. There have been phase 3 randomized trials done in the second line setting, comparing CAR T therapy head to head with high dose chemotherapy and autologous stem cell transplant. And we've recently seen a press release from Zuma 7, which has completed recruitment, reporting improved EFS for patients who have received the CAR T product compared to the standard chemotherapy and autologous stem cell transplant. And we really wait to see the data which will be presented in ASH this year. So hopefully in the future, the outcomes for our patients will be much better, and hopefully CAR T products are likely to be used more upfront than we are using them currently. So with that, I will conclude my talk, and thank you very much for your attention, and I shall be glad to take any questions. Thank you.
Thank you, Dr. Sridhar Chaganty, for again a very elaborative talk. So now we are moving on to our question and answer session. So we have got with us Dr. Sridhar Chaganty, and we've got Dr. Farooq Wanro with us. So I'll start with Dr. Farooq Wanro. Dr. Farooq, you've talked about myeloma and you've talked about fewer newer agents as well, including quadruplet therapy. So my question was around use of daratumumab upfront. You have shown some data that it has shown quite promising results, but obviously there is a question around cost effectiveness as well. So I think from UK perspective, what do you think that how you're using daratumumab at the moment, and what do you think that in future it would be?
Thanks, Dr. Usman. Yeah, obviously there is evidence base. If you look at the evidence from Griffin trial and Caspia trial in the transplant setting, and also in the Maya trial and acyclone for the elderly myeloma patients, there is definitely evidence of that quadruple therapy, including daratumumab-based treatment, gives a deeper response. It gives you deeper MRD and deeper response, but the data is not mature to show that it actually shows a survival benefit or a PFS benefit as yet. In UK, we don't have quadruple therapy approved as yet, except in Scotland. They have the Scottish Consortium have approved Dara VTD as an option for upfront treatment in transplant eligible patients. But I think if we look at what experts say, is they would say if you have a high risk patient, then this could be an option for high risk patients, those with 414 or 17p deletion. If you have done fish analysis at the beginning, not all centers do that. So that definitely would be an option for high risk patients.
Okay, thank you. So I've got another question to Dr. Sridhar Chaganti. Again, you've talked about CAR T-cell therapy, especially in the context of diffuse large B-cell lymphoma. So I think the first question was that you mentioned the outcome data and the real world data. And then in your second last slide, we talked about that, approximately the PFS is around 30-35% for patients who are having CAR T-cell therapy in the context of DLBCL. So my question was that if we took into account only those patients who are going to have CAR T-cell therapy actually, rather than, being fallen out in between the decision and having that infusion in the real world, it was looking at around 40-50%. Is it like that, or is it different than that? The outcome.
That's a fantastic question, Dr. Uthman. This is the problem with the way data is presented in the CAR T world, and all the pivotal trials were presented with infused patient data. It was not intent to treat analysis. And as you know, in scientific literature, we are really looking for intent to treat analysis. It's very analogous to presenting transplant data, where you only present data on patients who actually received a transplant, and you do not, include so many other patients that you considered for transplant but never made it to transplant. So, and that is a problem. And in fact, if you look at Juliet trial, which is the Novartis product, tisagenlecleucel, they enrolled 160 patients, and only 110 or less than 110 actually received the infusion. So there's a big dropout between enrollment and infusion. The axi-cell trials have had less dropout, but it depends upon how much screening you do for these patients. But that's where I think the real world data is really important. And in our hands, we see roughly around 25% of patients will drop out from the time you consider them from approved for CAR T therapy and reaching the infusion. So you can, if you look at all these figures, you can include a 25% reduction in their survival figures that you're talking about, because that is the intent to treat analysis. When we initially presented our UK data in ASH, it came for some criticism because, again, people look at best overall response rates with CAR T, best overall response rates and best CR rates. So by which you mean that if a patient has achieved a response at any point in time, that patient will be counted as a responder. But if a patient responds at 1 month and then progresses by 3 months, as we see 50% of patients do, is it really a meaningful response? So we tried to present a 3-month response rate at ASH meeting. That was our first data cut that we presented. That came for some criticism because our response rates look much inferior. So since then, we've started presenting both best response rates and a 3-month response rate, and best response rates will match. So there is a problem. I think the current therapy, there is still a long way to go for it to show better results.
Thank you, Dr. Sridhar. And on the same note, I've got sorry. Yeah,
sorry,
Dr.
Dr. Usman, further to the same question that you've just asked to Sridhar. Hi, Sridhar, this is Wakas here. So bearing in mind all these caveats, the real world data versus the published trial data, and also the high cost of CAR T cell, plus you mentioned that a large number of these patients ended up in ICU as well in the real world data. So there is an additional cost, inpatient stay, ICU cost. So where do you place CAR T cell therapy as compared to all the other, novel BiTEs and ADCs coming out showing very promising results in relapsed DLBCL?
So again, Wakas, that's a fantastic question. The answer I don't pretend to know. I'll give you my views and my feeling about where things sit. So CAR T is currently approved clearly, and we have data, we have follow-up of 2 years plus on some of these patients now, even in the real world. And I think it is fair to say that CAR T has revolutionized treatment for patients who are refractory to multiple lines of therapy. We've seen from the SCHOLAR-1 data and from real world series other than SCHOLAR-1 that outcomes for these patients who are refractory to multiple lines is 10% long-term survival, 15% long-term survival probably. From that, even in real world, now we are seeing something like 30-35% probably long-term survival. So I think that is a significant improvement to what was seen before. But we probably need to get better at selecting the patients who are more likely to benefit from the CAR T therapy. And in my talk, I showed some of the risk factors that we can see. I mean, it's almost pointless infusing CAR T therapy to some of these patients when you can see that they are going to do so poorly, especially where cost considerations are important. In terms of toxicity, I think we are much better now, Wakas, than what we were a couple of years ago. So our ICU admission rate is roughly around 20 to 30%. But most patients do not need support, and most patients will only spend a day on the ICU and they will come out. Often they go to ICU more for observation than for actual intervention or treatment. And in our own practice, now we have actually started managing more patients on the ward. So we send less and less to ICU compared to what we were 12 months ago. Even grade 3 neurotoxicity, we are now increasingly managing on our wards because there is that much more experience within the team, and the nurses are going to be critical, really, the nursing teams in managing these patients. And the cost, I agree, is a huge issue. Why it needs to be that expensive, I'm not going to get into that discussion today. You could argue it doesn't have to be. And I hope cost will come down with time as there are more products, different manufacturing techniques available. And comparison with BiTEs is a bit difficult. I think BiTEs are looking very promising. The response rates are really encouraging. We need to see a bit more long-term survival data because we've all been burnt with having seen, if I draw an analogy to ALL, for example, blinatumomab BiTE antibody can induce fantastic CR rates, but responses last 3 months. So I think, I'm not saying that's what it's going to be in the lymphoma setting. I think the responses are much better in the lymphoma setting. But we really need to see the 1-year survival, 2-year survival data to start thinking how this might relate or compete with the CARs. But I think that they will compete.
Thank you, Sridhar.
Okay. So we've got Dr. Amjad Hayat here with us as well. So Dr. Amjad, thanks a lot for the talk. And I've got a question for you as well. So actually 2. One is about that, if you've got a diffuse large B-cell lymphoma peripherally with the CNS involvement as well, off trial, how you would treat in your practice. That's one of the questions. Another question is that the way the CAR T cell therapy is emerging in diffuse large B-cell lymphoma, what's your thoughts are in the context of autograft and CAR T cell? I think, what's your thought that how the future is, moving in that direction?
Yeah, thank you very much, Usman. I apologize. I joined as an attendee. But to answer your first question, I guess if somebody presents with the CNS involvement at presentation, that would be considered as a secondary CNS lymphoma. The outcomes for secondary CNS lymphoma are extremely poor. The data is all retrospective. Mostly coming from the German Gerard Illerhaus's group, as Chris would have actually mentioned in his talk. And primarily the aim is to use treatment that is effective both in diffuse large B-cell lymphoma and is also CNS penetrating. I guess what you're probably pointing to the use of high-dose methotrexate in patients who have high CNS risk of relapse, which generally happens at 6 to 9 months. This has been extremely controversial. So all the previous data was retrospective, and I think most data came from the one of the German study where I think they wanted to use IT methotrexate in patients with high-risk group. Not all of them actually got the treatment, and it turned out that the IT methotrexate is not useful. This actually led to the use of high-dose methotrexate. This has actually been challenged last year by a large Canadian retrospective review, and is also going to be challenged again at this ASH by a large retrospective review in general. I think one of them has 2,500 patients, and the other one is actually Sridhar might actually know is from the UK group. From Toby Ayres, again, a retrospective review. So this probably means that we are going to be discussing it a bit more. I remember from last year, after the ASH presentation, everybody said the data is fine, it is retrospective, we will continue to use high-dose methotrexate. So I think it will be challenged after these two presentations. With regards to the CAR T in an upfront setting, or maybe as a first line at first relapse, data that was retrospective again from Mehdi Hamdani from CIBMTR suggested that if a patient is still chemosensitive and go into a complete remission, then I think you can't throw the child with the bathwater, so you should still consider an autologous transplant. And I think again, Sridhar might comment himself on the three, I think, press releases that came from the three companies, of which the Novartis product it has a negative study. The other two suggest that CAR T could be used in first relapse.
Okay, thank you, Dr. Amjad. So Dr. Waqas, have you got any other questions?
Yes, unfortunately, Dr. Chris Fox couldn't join us because of his family commitments. So I have a question related to primary CNS lymphoma, and obviously Dr. Amjad and Sridhar and Farooq can take that on. Chris represented the data around matrix regime and an upfront autologous stem cell transplant in primary CNS lymphoma. What our experience has been here in our part of the world is that matrix, even without the thiotepa, rituximab methotrexate is proving to be very toxic. So over 40, even 50 years of age patients are not really tolerating matrix, and we've had mortalities with sepsis. Bearing in mind, we have got a number of bugs here, which are non-existent in your part of the world. So about 25-30% are MDR carbapenem resistant organisms. So I think what are your views on using regimens like RMPV, the MSK protocol, where you start off with just rituximab and high-dose MTX, and then later on the cytarabine comes in after about 5 to 7 cycles. In our experience, that seems to be doing the job better because it's well tolerated by our patient group.
Maybe I
So,
can take it,
yeah,
because it
Sridhar,
is,
yes.
I think what you outlined is a very good thought. I would encourage you to do it in a kind of collaborative effort with a few centers and publish your experience. If you heard, Chris mentioned the Optimate trial, which is the next trial following on from the ILSG32 trial. And that trial is trying to do exactly what you outlined just now. It is trying to de-escalate the matrix treatment, because matrix is toxic. We find it to be toxic. I think patients up to the age of 60, 65 who are otherwise fit and well do fine with matrix, but even in the pivotal trial that was done with matrix, the mortality was something like 8% treatment-related mortality. So it's not small, and I'm not surprised that you are seeing much more in the real world. I think in Chris's talk, he would have outlined on the Optimate trial, the plan is to actually start with rituximab and methotrexate as the first cycle for patients, and then just give a couple of cycles of matrix rather than give full 4 cycles of matrix. And if a patient is responding, take them to an early autograft. So if you demonstrate chemosensitivity, take them to an autograft. Don't bother delivering all the 4 matrices. I guess I cannot recommend it as, because it is still a trial being done. There'll be randomization between 4 matrix versus that arm. But you're speaking from a practical point of view. You can't deliver 4 matrices. And if this is what your approach is, you should just do it, collect the data, present it.
Yeah, if I can interject, I would agree with Sridhar. Now, I mean, being in Europe, we have tended to follow the IELSG group, and that is why I personally use matrix followed by the autologous transplant. I think the important thing is the consolidation here, which is the one that has really improved the outcome. So again, taking into account the toxicity issues, certainly the Boston group from Tracy Batchelor and James Rubenstein from the Californian group, they have also, and historically from the NCI group, Lisa DeAngelis, the Americans have actually always used high-dose methotrexate as their backbone. So the RMPV data would be perfectly fine, and I think it is a good regimen. The only thing I would suggest is that you do consider in fit patients who could go for an autologous transplant as consolidation.
Okay, thank you, Dr. Amjad. Thank you, Dr. Sridhar, and thank you, Dr. Farooq. So I think we are pushed for time. Thanks a lot for wonderful presentations and for this Q&A session, which you've taken your time out as well for that. So again, thanks a lot, and thanks a lot for all the attendees who have joined us. Hopefully, we'll be having further sessions next year as well. So goodbye and Allah Hafiz from our side for now. Thank you.
Thank you. Take care.
Thank you.